Okay, so aging, smoking, inadequate nutrition, and then of course we know a lack of exercise. A lack of exercise can cause a lot of problems in our body. Our heart is a muscle, just like our legs and our arms and all the other muscles we have. So we need to exercise our heart as well. And if we don't, we obviously will have issues. There are medication considerations. So some of our heart issues can be caused by medications. Some of the over-the-counter things that we can take and herbal remedies can cause oxygenation and cardiopulmonary issues. Nutritional supplements, all of these can have an impact on our blood pressure, our pulse, and our cardiac function. Our prescription medicines are a big thing that we're going to want to think about, especially when we're treating patients for hypertension. It's very easy when we're dealing with the heart to try and fix one problem, but then inadvertently we cause another problem, just like with IV fluids when we're trying to fix a patient that's dehydrated and we give them fluids. Well, sometimes we take them over and we cause fluid overload. So it's kind of the same thing with medications. We try and treat high blood pressure and we give them medicine to bring it down, but then the medication takes their blood pressure too low and that causes a whole nother set of issues. We have lifestyle considerations, so exercising again, dehydration related to just exercise or just not drinking enough water in general. If we're doing drugs, going through alcohol withdrawal, how much caffeine. Caffeine has an effect on the heart, and then anxiety can also have an effect on our cardiopulmonary status. And then we also have to think about environmental considerations, especially with oxygenation. So different jobs that we may have, just the air pollution in general, if we're smoking, any exposure to lead. This is a big issue that we see with pediatric patients because they're so little and they get around and they're by the windowsills and they pick things off and they put things in their mouth. And then psychological health considerations. So anxiety, we said that can have a cause stress on our heart. Stress in general increases our heart rate. And then over time, there is a direct link between stress and heart attacks and an increased development in different heart issues, which we'll talk about. And then depression. So it is proven that patients that suffer from depression are also at risk for developing heart attacks. Your patients might not be exercising. Again, the heart is a muscle. We have to make sure that we're exercising the heart. And then we also have to take care of what we put in our body. So we have to make sure that we maintain a healthy body. We don't want a lot of high fats, a lot of carbohydrates. They are not good for us. So what kind of alterations can we have in our cardiovascular system? So we can have what we call dysrhythmias or arrhythmias. So these are two words that you will see used interchangeably. They mean the same thing. A dysrhythmia or an arrhythmia is a conduction disorder that results in an abnormally slow or a very fast, rapid heartbeat, or one that does not proceed through the conduction system in a usual manner. So we're going to go over a little bit of the anatomy and physiology and refresh your memory at the cardiac cycle and the electrical system behind that. So sometimes it just skips a part. It goes too fast. One part of it doesn't work. So that's when you start to see these abnormalities. We can have myocardial ischemia, which this is going to occur when the blood flow to your heart is reduced. It's preventing that heart muscle from receiving all that oxygen-rich blood. We have angina. Angina, you guys have probably heard of. It's just another fancy nursing word for chest pain. Myocardial infarction. So this is a heart attack. We can call it an MI or a heart attack or a myocardial infarction. You can use those words interchangeably in the healthcare setting. This occurs when there is a blood flow decrease or blood flow stops altogether to a part of the heart and it causes damage to the heart muscle. And then we have heart failure, which can be chronic. It is a progressive disease, so you can't really change it. You just have to manage the symptoms. It gets worse, and it's when the heart muscle is unable to pump enough to meet the body's demands for blood and oxygenation. So this is going to be, these next couple of slides are just going to be a refresher. So how does the blood flow through our heart? So the lungs and the heart are both working together to be able to circulate that oxygen-rich blood to perfuse all of our organs. So blood flow is going to start on the right side of the heart. The blood enters the heart through the two large veins. We have the inferior and the superior vena cava. It's going to empty that oxygen poor blood from the body into that right atrium. As the atrium contracts, the blood is going to flow from your right atrium into your right ventricle through the open tricuspid valve. When the ventricle is full, the tricuspid valve shuts, and this is going to stop any backflow of blood into that right atrium when that ventricle is contracting. As the ventricle contracts, the blood is going to leave the heart through the pulmonic valve into the pulmonary artery, and then going to go to the lungs where it becomes oxygenated. The oxygenated blood is then going to return to the heart through the pulmonary veins. Okay, so that's the right side of the heart. Now the left side of the heart, the pulmonary veins are going to empty all that oxygen-rich blood that we just oxygenated from the lungs into the left atrium. As the atrium contracts, blood is going to flow from your left atrium into your left ventricle. It's going to go through the open mitral valve. When that ventricle is full, that mitral valve is going to shut. This is going to, again, keep that blood from flowing backwards into the atrium when that ventricle is trying to contract. And as the ventricle contracts, blood is going to leave the heart through the aortic valve into the aorta, and then it's going to go out to the body. And then it's going to circulate to all the organs and perfuse everything. So some more anatomy and physiology. So we do have 4 chambers in our heart. So we have the upper chambers of the heart. So you're going to have your right atrium and your left atria. We're going to have 2 ventricles, which are the lower heart chambers. You have your right ventricle and your left ventricle. In the middle here, in between the right and left ventricle, we have the septum. And then the right side of our heart is going to be responsible for the pulmonary circulation. And the left side of our heart is going to be responsible for systemic circulation. So it's really important that you guys understand what the right side of the heart does and what the left side of the heart does, because I think in your last lecture, we're going to talk about heart failure. And we have 2 kinds of heart failure. We have right-sided heart failure and left-sided heart failure. And the symptoms that you see for each type of heart failure are going to be very different. So if you know what each side of the heart does, then you are going to be able to better understand what's happening in the body and what type of symptoms you would see in your patients. So the right side is pulmonary circulation. The left side is that systemic circulation. It's going to perfuse all of your organs. So when we talk about our blood going, the big take home that I want you guys to get out of this lecture today is that that left side of the heart is responsible for perfusing all of your organs. So if the heart's not pumping effectively, all that oxygen-rich blood is never going to get to your kidneys. It's never going to get to your liver. It's never going to oxygenate your peripheral extremities. And this is when we start to see issues. So any disease state that we talk about that affects the heart, or the possibility of the blood getting to the organs and your extremities, that's where you're going to see your major issues. All right, so we know that our cardiovascular system is extremely vital for the exchange of gases. Our heart is composed of, the cardiovascular system is composed of the heart and the blood vessels. So the heart has those upper chambers that we just talked about, the right and the left atria. They are going to receive blood from the veins, the superior and inferior vena cava, and the left and right pulmonary veins. The lower chambers, which are the right and left ventricles, they're going to take that blood and they're going to force it out of the heart through the arteries. That's going to happen via the left and right pulmonary arteries and the aorta. So what is perfusion? So perfusion is the exchange of blood, gases, and fluids between the vessels, tissues, and organ systems. So our cardiac tissue is made up of a couple different layers. So we have 3 layers that actually help make up that heart wall. So we have the epicardium, the myocardium, and the endocardium. So the epicardium is that outer layer of the heart, which is composed of fibrous and loose connective tissue. Our myocardium, that's the middle layer, that's going to consist of some muscle tissue, and this is the actual force behind the heart's pumping action. So that's the muscle. And then the endocardium, that's going to be the innermost layer, and that is composed of a thin, smooth layer of endothelial cells, which forms the heart valves. We have the pericardium. That is what they call a sac-like structure. That's going to actually surround and support and protect the heart. It's made up of 2 membranous layers. So we have the parietal layer and the visceral layer. The parietal layer is the outer layer, which is very tough and very hard because we want to be able to protect the heart. And then we have a visceral layer. That's going to be the inner layer. This actually adheres to the heart, also called the epicardium. The parietal pericardium is very dense. So that way it can protect the heart of all those important parts of the heart. And then we have the serous fluid between the layers, and that's going to help reduce any friction. So this is just a good picture, shows you everything that we were talking about, your ventricles, your atriums, your pulmonic valve, your aortic arch, all that good stuff. This picture is also in your book if you want to take a look at it in depth. So let's talk a little bit about our heart valves and our AV valves. So our heart valves are membranous structures that help ensure that all that blood passes through the heart in a one-way forward direction. We don't want any regurgitation at all. We need everything in order for to have the perfect cardiac output and to properly perfuse all of our organs. We need that blood supply to go in a one-way direction. We don't want it to go backwards. Sometimes we do have issues where it does go backwards, and that's where we start seeing these heart issues, and we're going to talk about them. Our atrioventricular valves, also called your AV valves, you might hear that, they might just say the AV valves in the clinical setting. So these separate the atria from the ventricles. And they prevent blood from returning to the atria when those ventricles contract. They are cusped and they are leaf-like. You have your tricuspid valve, which is in your right atrium and ventricle, and then you have your bicuspid valve or your mitral valve, which is in your left atrium and your ventricle. Attached to the tricuspid and your mitral valves are your chordae tendineae. These are described as cord-like structures. They attach to the papillary muscles and they contract and they help apply that attention to, or apply the attention to the AV valves. They make sure that those valves close when those ventricles are starting to contract, and they keep any blood from regurgitating back into the valves. We have our semilunar valves. These prevent blood from flowing back into the ventricles after the heart contracts. Our pulmonic valve in our pulmonary system, this is going to be between that right ventricle and the pulmonary artery. And then we have our aortic valve, which is between the left ventricle and the left aorta. So what happens is the ventricles are going to contract. This is going to force the blood into that pulmonary artery and aorta. Relaxation follows. There's going to be a fall in pressure in the ventricles, which causes the pulmonic and the aortic valves to close, thus preventing backflow into the ventricles. This is just a good picture. So here's your aortic semilunar valve right here, your pulmonary semilunar valve, and then you have your bicuspid valve and your tricuspid valve. All right, so we have, we're going to talk about arteries and veins. So there is a difference, and you need to really have a good understanding of what our arteries do and what our veins do, because we're going to talk about different disease processes that affect our arteries and veins. So our arteries carry that oxygenated blood away from the heart. They are the smallest arteries, are called arterioles. They are responsible for dilating or constricting, and they help accommodate changes that our body sees in blood flow. And then we have our veins. Our veins are responsible for carrying all that deoxygenated blood back to the heart. The smallest veins are called venules. They are thinner veins than arteries. The pressure in the veins is lower than we see it in the arteries. They're larger diameter, but there is lower venous pressure. So our arteries are responsible for carrying that oxygen-rich blood from the heart out to the body, and the veins bring that deoxygenated blood back to the heart. Arterioles actually branch off, and they actually will turn into capillaries. And then our capillaries are microscopic vessels. They work together to form a connective network between those arterioles and the venules. They are a one cell layer thick, and they have direct contact with all of the cells of our tissues. And they are responsible for delivering that oxygen and metabolic substances to our cells, which our cells need in order to work properly. So our cardiopulmonary circulation, again, we have the inferior and superior vena cava. Those are going to be the largest veins in the body. They're going to bring that venous deoxygenated blood, remember that that's deoxygenated, into the right atrium. The atrium fills with blood, the tricuspid valve opens, the blood travels to the right ventricle and is pumped into the pulmonary artery. Our pulmonary artery is then going to deliver that venous blood to the right and left lung. In the lungs, we're going to see that exchange of oxygen in the inspired air for that carbon dioxide in the venous blood. The CO2 is transferred then into the alveoli, and it's going to be exhaled. The pulmonary veins are going to bring that oxygenated rich blood into the left atrium. The oxygenated blood is going to flow out of the left atrium through the bicuspid or the mitral valve and into the left ventricle. The left ventricle will then pump the blood into the aorta. And then lastly, that aorta is going to take all that oxygen-rich blood from the heart and deliver it to the body's cells and the tissues. So those coronary arteries, left and right, they're going to supply that oxygenated blood to the cardiac muscle. We have something called the coronary ostia. So this is the opening area in the coronary arteries. This is going to be responsible for delivering that oxygen-rich blood to the myocardium. Our coronary veins carry away that carbon dioxide that was produced by cellular metabolism. And our coronary veins empty into the coronary sinus in the right atrium. Our blood mixes with blood from the inferior and superior vena cava, and it is recirculated into the lungs. So this is just another great picture of all the arteries and veins in the heart. There's the aortic arch, and then it's showing you the inside here, how you can see that left ventricle, that coronary ostium, and then this is actually the wall of the aorta. And these pictures are in your book if you want to refer back to them and look more at them. Just another really good picture in your book that shows the structure of the heart. The arrows actually show the course of blood through the chambers of the heart. In case you guys need a visual, most people are visual learners. All right, this is just a good example again of the cardiac cycle, which we have talked about, the atrial filling, the atrial contraction, the ventricle filling, and the ventricular ejection. So our cardiac cycle, so it's actually a sequence of electrical and mechanical events in the atria and the ventricles that result in a heartbeat. So it does include two components. We have your diastole and your systole. So diastole is when the heart is at rest. Your ventricles are filling. Your systole is once your ventricles are filled and they start to contract. So one thing I want you guys to think about with diastole is this is the period when your heart is at rest. So sometimes when we see blood pressures 200 over 110, 189 over 110, it's very worrisome when we see that diastolic number get up like that, because that's the pressure in your heart when in the ventricles when there's nothing going on. So that's not a good sign. So I want you guys to think about that. We worry about both numbers, but we really worry when we see those high diastolic numbers. And then we have our atria fill. So they contract together to fill the resting ventricles. That's diastole with blood. The pressure from the accumulating blood in the ventricle causes contraction. That's your systole. You're going to have that brief pause, and then the cycle repeats. So our heart is actually a conduction system. It sustains the electrical system of the heart. If we don't have this electrical system working, we're not going to have a heartbeat. So we have our SA node. The SA node is right up here at the very top. It is located in the posterior wall of the right atrium. This is considered the pacemaker of the heart. That's important for you guys to know. I want you guys to know that. You're going to see that information again. So it is considered the pacemaker of the heart. It initiates that electrical impulse that's going to be responsible for the heartbeat. And it's going to make about 60 to 100 impulses per minute, which we would see reflected in our heart rate. We have our atrioventricular node, or our AV node, which is right down here, right above the right atrium. This impulse reaches the AV node and is delayed a few hundredths of a second. The ventricles are filling. The impulse is then going to travel through the bundle of His, which is right over here, this little area right here. It then is going to travel into the bundle branches right here. So we have a right bundle branch and we have a left bundle branch. And then it's going to go into the Purkinje fibers, which are right here at the end. So I want you guys to know where these bundle branches are, because we are going to talk next lecture about different blocks. And this is one of the places where we see blocks. We can have a right bundle branch block or a left bundle branch block. And then our Purkinje fibers are responsible for that ventricular contraction. That's their job. All right, so we talk about polarization and depolarization. I need you guys, this is an important slide for you guys to know. So polarization is going to happen during diastole. This is when the myocardial cells are at rest and before the impulse is generated. So that's polarization. Depolarization is going to be what we call a transfer of ions. This is when positive ions are going to move into the myocardial cell and those negative ions are going to move out. This is going to cause our cardiac muscle to contract. So depolarization is cardiac muscle contraction. Polarization occurs during diastole. Polarization and depolarization first occur in the atria, and then it's going to happen again in the ventricles. Repolarization occurs after depolarization occurs. Those ions get together, they realign, and they wait to have another electrical impulse, and the process starts all over again. What we have a refractory period. So this is the period where cells are going to be resistant to any kind of electrical stimulation. And then a certain test that we would use to detect any kind of electrical activity in the heart to try and diagnose any kind of heart problems would be what we call an ECG. It's an electrocardiograph. So we call it an ECG or an EKG. Those terms are used interchangeably in the healthcare setting. All right, so test your knowledge. Which of the following is the correct sequence for normal electrical impulse movement through the cardiac conduction system? A, pulmonary veins, left atrium, right atrium, pulmonary arteries. B, Purkinje fibers, bundle of His, AV node, SA node. C, SA node, AV node, bundle of His, Purkinje fibers. Or D, vena cava, right atrium, left ventricle, and then the pulmonary artery. What do you guys think?
C.
Very good. Yep. Starts at the SA node, goes to the AV, through the bundle of His, and then to the Purkinje fibers. Good job. All right, so regulation of the heart. So regulation of our heart occurs through stimulation of the autonomic nervous systems, which then affects our heart rate through the sympathetic nervous system. So our sympathetic nervous system is going to be responsible for the increases that we see in our heart rate. Our parasympathetic nervous system is going to be responsible for any decreases that we see in our heart rate. We do have something called baroreceptors. So these baroreceptors are located in the walls of the atria. They are pressure sensitive nerve endings. We also find them in our major blood vessels, the vena cava and the arch of the aorta and our carotid arteries, and they are going to affect our heart rate. The main function of baroreceptors is that they are going to sense the pressure from the blood as it stretches through all of our vascular tissues. So it's going to be responsible. This is another compensatory system in our bodies. It's going to work to control our blood pressure. So when it senses our blood pressure decreases, those baroreceptors sense it. They're going to, in turn, send an impulse to the brain. It's going to activate that sympathetic nervous system. It's going to increase the heart rate, which is also going to increase our blood pressure, right? Because if we increase how much blood we're putting out of our heart, we're going to increase our volume. When the blood pressure is stabilized, the heart returns to normal. Then we have chemoreceptors. These are structures that are very sensitive to the pH and the CO2 in our body. You guys just finished learning about that in Concepts 1. It's located in the carotid bodies, the aortic bodies, and the medulla of the brain. These help regulate sympathetic stimulation or inhibition, and they will also alter our heart rate. So what happens is our body has a fall in pH levels and a rise in carbon dioxide and a decrease in oxygen. This whole process is going to cause an increased heart contraction, which is then going to affect our pH and our CO2. It's going to cause it to become normal, and then the heart, hopefully it'll cause it to be normal, not always, then the heart will return to normal. So the body tries to use these compensatory mechanisms to fix things the best that they can. It's not always possible. Sometimes that's when providers like us and doctors have to prescribe medications, and then we have to use pharmacological interventions to try and fix them. So a couple things for you guys to know. You guys need to know about this. This is an important slide. So our cardiac output is the amount of blood that's pumped out of our left ventricle in 1 minute. The normal adult will pump out about 4 to 8 liters of blood a minute. That is a lot of blood. Our stroke volume, that is the amount of blood that gets pumped per contraction of the heart. So that's just the amount of blood that comes out every time the heart contracts. That is going to average about 65 to 70 mLs. And then if we want to figure out how to calculate cardiac output, which you guys need to know how to do, there's a simple calculation. It's going to be your heart rate times your stroke volume is going to equal your cardiac output. Very simple. Cardiac output equals your heart rate times your stroke volume. So if a patient's heart rate is 75 beats per minute and their stroke volume is 68 mLs per stroke, what is the cardiac output? Well, we use this formula, heart rate times stroke volume. So your cardiac output equals 75 times 68 for a total of 5,100. All right, so more about those chemoreceptors. So the location and the innervation of the aortic arch and the carotid sinus baroreceptors and the carotid body chemoreceptors. These chemoreceptors regulate that sympathetic stimulation or inhibition. It's going to be very sensitive to the pH and the carbon dioxide and the oxygen levels in our body, and we find this in our brain. So some things that we want to think about when we are doing an assessment of our patients and we're looking at their cardiovascular system. So it's really important that we talk about any past medical history or any family history. So we want to know about any cardiac disorders that affect their family members, because there are a lot of heart issues that have familial and genetic predispositions. So you want to ask your patients if their close relatives are still alive. And if they're not alive, then you want to dig a little bit deeper. Well, when did your mom or dad die? How old were they when they died? What did they die of? If you guys have ever been to a physical, one of the questions that they usually ask you if you're getting a good assessment is, have you had anyone in your family that's ever died of a heart attack before the age of 40? Because that can be a sign of a cardiac issue that could be passed on through genetics that you could be susceptible to. So it's really important, find out about their past medical history. If they have irregular heart rates, do they ever notice if their heart is palpitating? Do they ever feel like they have any skip beats? And then definitely that family history, very, very important. Then we want to know about any prescription and non-prescription drug use that they have, because a lot of the prescriptions that they take can affect their heart rate or their blood pressure. And then we all know about the impact that over-the-counter medications, herbal remedies, all those have a huge effect on our body. So make sure you're asking about any herbal substances that they're taking, because they can cause adverse reactions and drug interactions with things that you might prescribe. So we want to know if they are having, if they're participating in the use of any illicit drugs, in particular cocaine or methamphetamines. These directly affect the heart. And then we want to know if they have any drug or food allergies, because there are certain drug diagnostic procedures that may involve the administration of drugs. If we do like stress tests, angiograms, things like that, we give them dye. So we want to know if they have any allergies to iodine. We're going to talk more about that. So we want to know why the patient's coming in. What did they come in for today? So a lot of times if you work on a med surg floor, you will get these patients after they've been in the emergency room. I always make sure that when they come up to me and I get them as a new patient, I always repeat exactly why they were here. Tell me a little bit more about why you came. Sometimes they don't tell the people everything downstairs in the emergency room. They forget things. You want to make sure that you have a good understanding of why your patient is there, because you're going to be planning their nursing care around why they are coming in and what you see in the computer. And it's a good opportunity for you to say, hey, they told me in the emergency room you came in for a fall. And they might say, well, I didn't come in for a fall. This is why I came in, because anything can get put into the chart incorrectly. So always make sure you're talking about what they're currently there for. And you want to you want them to describe to you any symptoms that they're having. Because if they're having chest pain, if they're having shortness of breath, if they feel like their heart is beating rapidly, if they're feeling dizzy, they feel like they're going to pass out, if they're having severe headaches, these are going to determine how urgent you are in the care that you provide to them. So important things that you are going to want to assess for signs and symptoms. So chest pain or discomfort. And when they say, oh, I have chest pain, well, you always want to ask a little bit more. Tell me where your chest pain is. Is it on the left side or is it on the right side? Always more concerning if it's on the left side. Do you have any numbness or tingling going down your arm? Does the pain come down your arm? Does it go into your shoulder? Does it go into your neck? These are all signs of a heart attack. Is there anything that makes that pain better? Is you're just getting chest pain when you walk around, but then when you sit down, it's better? Or is it fine when you're sitting down and then when you start to walk around, it gets worse? You want to know, do they have any shortness of breath or any dyspnea? So if they say, I'm feeling short of breath, okay, look at them, look at their work of breathing. Are they just short of breath when they're sitting there, or are they walking to the bathroom and then they're getting shortness of breath? These are all important. We want to talk about edema and weight gain. These are significant indications of heart failure. If our heart cannot pump enough blood to get that full cycle going, right, to get all that blood circulating around and back to the right side of the heart, that blood's going to pool. When that blood starts to pool, we're going to see edema. Patient's going to hold on to fluid. We're going to see weight gain. And then palpitations. Are they having any palpitations? If they are, what does it feel like? Do you have any pain when you have palpitations? Palpitations with pain is usually a sign of something not so good. Can mean a couple different things. Usually palpitations with no pain, we don't worry about. Palpitations with pain could be a significant finding of something more serious. And then fatigue. Patients that have heart issues, they're more tired than other patients because they're not getting that oxygen-rich blood through their body. So they don't have the oxygen, they feel fatigued. And because they're not getting that blood throughout their entire body, they're going to experience dizziness. They're going to have syncopal or near syncopal episodes. So syncopal would just be where they completely pass out. Near syncopal is where they felt like they were going to pass out. Maybe they fell on the floor, but they didn't completely lose consciousness. And you're always going to want to assess that level of consciousness, because when we have a patient that presents with a sudden change in level of consciousness, this means that they either have a severe infection, could be a UTI, or something's going on and they're not getting that oxygen-rich blood to the brain, which is having an impact on their level of consciousness. So that history of present illness and those descriptions of any present symptoms are very important. So then we're going to do a physical exam. So we're going to look at their general appearance. When you guys walk into a room, you're always doing that snapshot. What does your patient look like? Are they sitting up in bed? Do they have a smile? Are they hunched over? Do they have a lot of work of breathing? Do they have cyanosis? Is it around their lips? Are their fingers blue? What do they look like? Are they on oxygen? How many liters of oxygen are they on? Look at that general appearance. Look for poor circulation causes. So they could have a reduced blood supply to the heart because they have ischemia. They could have damage to the heart now. A classic sign is pain in the chest. What happens is we have a lack of oxygen to the heart. The heart is a muscle. Or we'll see leg pain when we get that lack of oxygen to our muscles. So people that have chronic health issues, that have angina, that are having heart attacks, heart failure, they complain of chest pain. Some of it they might have all the time, and we control it by medication because the heart's damaged and they're never going to regain the appropriate amount of oxygen to the heart. And the same thing with the legs. A lot of people that have heart issues complain of leg pain when they're walking because they have a lack of oxygen to their muscles. So then we're going to look at their vital signs. So we want to see if they have a temperature. We know if they have a fever, for one, it can cause an increase in their heart rate, right? It doesn't mean that they have anything wrong with their heart, but we know that they can become tachycardic. But fever can also be present with some types of heart disease. So certain infections like rheumatic fever and endocarditis, these all present with a fever. So these are things you would want to explore on. We want to take a look at their pulse. So we want to note their rate. Is it irregular or is it regular? How fast is it? Is it between 60 and 100? Is it 42? Is it 110? These are not normal rhythms. And we want to know the quality and the volume. So we want to feel those peripheral pulses. We want to note if there's any type of a pulse deficit. So remember, a pulse deficit is the difference between auscultation at the apex of the heart. You guys remember that from your first semester. You're listening at the apex and then palpating that radial pulse for 1 minute. So then you're going to compare the two, and then there's any difference in numbers is going to be what we call a pulse deficit, which can be a signal of a heart problem. It could be a couple different things. And then you want to feel those peripheral pulses. You want to compare each one right to left. And then you also want to do your lower extremity pulses, because you might, it's very oftentimes we see that patients with heart problems will have good peripheral pulses in your upper and lower upper extremities, but they don't have it in their lower extremities because our arms are closer to the heart. So we will see those good right and left arm pulses, but not in our lower extremities. And then we want to look at the respiratory rate. So that use of accessory muscles, do they look like they're really having a hard time breathing? Do we see those accessory muscles? Is their breathing labored? Are their breaths deep? Are they shallow? Are they absent? Maybe they don't have any breathing at all. That's a problem. And then we want to look at their blood pressure. So we want to be able to determine a baseline, right? We want to know what their baseline is for when they're here. We might not always see what their normal baseline is if they've come in for some type of a heart issue or a blood pressure issue, but we need something to compare it to. Because if they come in with high blood pressure, then how are we going to determine if their blood pressure medicine is working? Or if they come in with low blood pressure, we want to know the medicine we're giving is helping. So we need to know what that baseline is when they come in. And it's always helpful to say to the patient, if you get a blood pressure reading that's like 98/60, that's low. But for this patient, that might be their baseline normally. It is not a normal finding. So I hear all the time from the techs, they come back and I'll say, hey, their blood pressure was 88/40. Well, they told me that's their normal. Well, that might be their baseline, but it's not normal. Okay, that is a low finding. My blood pressure is always 98/59, 62. Is it my normal? Yes, but is it really normal? No, it's not. It's a low blood pressure. And then we might have to look at them orthostatically. So if you guys remember what orthostatic blood pressure is, that's when we text their blood pressure in the supine position, then sitting, and then standing. And we're looking for those drops in systolic or blood pressure between the three. These can be indicative of certain heart issues. All right, so when we talk about our cardiac rhythm, we said that our heart is actually the thing that starts our heart going, our heartbeats, is electrical activity, okay? It's not mechanical, it's electrical activity. So one way that we can look at our heart's electrical activity is we can do what we call telemetry, which is continuous bedside monitoring. So we put I'm going to show you some pictures on the next slide. We put a monitor on the patient's heart, has a couple different leads, 5 of them to be exact. It's hooked up to a little box. We put the little box in a pouch inside their gown, and they wear it continuously. That's why it's called continuous bedside monitoring. It monitors either to what we call a monitor station at the hospital, which is a specific room that has nurses that sit in there, and they're responsible for monitoring everyone's heart rate in the hospital. But usually it also goes out to your nurse's station where you have a computer and that you are able to look at your patient's heart rate. So that's continuous bedside monitoring. We also can do an ECG, which is that electrocardiogram, or we call it an EKG. And these two will reveal the electrical activity of the heart, but not the mechanical activity. So if there's issues with the valves and things like that, it's not going to show us that. So our mechanical activity, this is palpating our peripheral pulses and then auscultation of the apical heart for 60 seconds. This is how we can evaluate the mechanical activity. And then we have to remember we always want to do a comparison. So we always want to compare what we're feeling to what we are seeing. So always take a look at the mechanical and the electrical. So a good example of this is we get alarms all the time on our telemetry monitors. It'll say asystole, or it'll say VTAC. It'll have a heart rate of like 189, or say a heart rate of 0. So you run to the room because you think that there could be something real. And then you get there and the patient's just sitting in bed and they're fine, they're eating and they're talking. So if you see a heart rate of 0, you don't necessarily have to run in and start doing compressions. You want to evaluate the patient. So look at what you see on the monitor, but then go in and check your patient. You don't want to call a code and then everybody gets to the room and your patient's in there eating her lunch. Okay, so you got to compare the two, patient with what you're seeing. And then sometimes our electrocardiograms can appear normal, even when there's a mechanical function in the heart. So it's not always 100% indicative of a problem in the heart. So our normal heart sounds, we have our S1 and our S2, that lub-dub. Our lub is our S1, our dub is our S2. We are always going to listen at the apex of the heart. We know we have abnormal heart sounds, and S3 is always going to be heard after an S1 or an S2. We also call that a ventricular gallop. And S4 is an extra heart sound that we hear just after the S1. And this is an atrial gallop. We also have murmurs and clicks. These are usually caused by blood flowing through some type of a diseased valve. And then we can have what's called a friction rub. So this is when we see inflammation in that pericardium and those layers are rubbing together. So then when we're looking at our peripheral pulses, again, we're going to palpate all of our peripheral pulses, our arms and our legs. And then, so especially with patients that you know that you have heart problems, you are definitely going to do the arms, the wrists, and then you're also going to do, so I would go and do the popliteal pulse. If you have good pulses there and you can feel them, well, you don't have to do the femoral because you obviously know you have pulses in your popliteal. But then I would also go and do the pedals. because I want to make sure that how, how bad is their heart issue? Are we not getting any type of pulses at all to the feet, or are they very diminished? Do we have to use a Doppler to find them? So really important that you do extensive pulse checks in these patients. All right, so these are the areas, again, just a refresher of where you can auscultate these heart sounds. So we can do it in the aortic area. We can do it in the pulmonic area. You have the Erb's point. These should all be a refresher from your fundamentals class. Our tricuspid valve, that left ventricular area, we also call that the apical area, right? How long do we listen when we are listening to an apical pulse?
5.
Say that again.
1 minute.
1 minute. Yeah, very good. 60 seconds, a whole minute. Yep, in the tricuspid area. So these are all the areas where we can listen to the heart. So when we're doing that cardiovascular assessment, we're going to look at skin. If your patient has a significant heart issues and they're not getting that oxygenated blood throughout all the vital areas of the body, you're going to see it in their skin. You're going to check for cyanosis and pallor. So you're going to be looking for any kind of skin color change to those mucous membranes. So you're going to open their mouth, you're going to pull open their lips, you're going to look at their gums, you're going to look at their tongue inside their cheeks, you're going to look inside their earlobes, check their skin in general, compare their upper extremities to their lower extremities, because again, our upper extremities are very close to our heart. We might not see changes, but then when we get down to our legs, where it's harder to get all that blood down to the lower extremities, then you're going to start seeing those changes. You go and look at the skin, look for changes in colors. You're going to look at the nail beds. We're going to be doing that capillary refill. Remember when you're doing it in women, if they have nail polish on, or if they have, sometimes these patients will have issues with their nails because they haven't had oxygenated blood to those areas. So you can always do that capillary refill on the back of the toes and the back of the fingers. Sometimes in certain cardiac issues, you will have sparse hair growth over areas that don't get a lot of oxygen, those thick toenails, and then you might see varicosities. And then again, compare those bilateral extremities, upper and lower. We're going to be checking for peripheral edema, because remember we said if that heart is not pumping, that blood can't make that whole full cycle back to the right side of the heart. So that blood's going to pull. You're going to see edema. Pitting edema. So we're going to scale pitting edema on a scale of 1 to 4. 1 is the least amount, 4 is very significant. You're going to check those dependent body parts. When we say dependent body parts, we're talking about those body parts that hang, so your feet and your ankles. We can see swelling in our feet, our ankles, our fingers, our arms, and especially in our patients that don't get up, that are kind of bedridden, we're going to see it in their sacral area and in their hips. And we're going to be monitoring their weight. So an increase in weight can be indicative of edema. Our weight is always going to be the most accurate indicator of our pulmonary function with comparison to edema. So you guys need to understand that. You are going to check the weight. You're going to see that again on your exam. You need to check the weight. When we do daily weights, we have to make sure that they're getting done. So I hear it all the time in the clinical setting. The doctor will come around in the morning to the AM nurse and say, what was the patient's daily weight this morning? Well, it looks like the tech didn't do it. Well, it's not just the tech's job, it's your job. Your job first and foremost. If you want to delegate that job to a tech, that's fine, or a CNA, they can do it, but you need to follow up and make sure that it's done, because we change our medications based upon the weight of the patient. And then we want to make sure that we are being accurate with how we weigh them. So we want them to be in the same time every day. So usually in the hospital, at our hospital, we do them at 6 a.m. in the morning. You want to weigh them in the same clothes. If they can get out of bed, get them out of bed and do a bedside scale. It's going to be the most accurate. And then if you have to do a weight in a bed, make sure that you remove all the bedding. You don't want to weigh them with their covers. If they have 6 covers on and 5 pillows, that's going to be an inaccurate measurement of your patient. If you have to zero the bed out, make sure you're zeroing the bed out when they first come. These are really important because the doctor is going to continue to give them probably Lasix and other medications that they may not need. And if we continue to do pharmacological treatment that we don't need, we're going to cause more problems for the patient. So those daily weights are extremely important. And then we're going to assess those jugular veins. So we're going to look for distension. So how do we look for jugular vein distension? We have our patient turn their head to the right or to the left, and we're looking for that pulsating vein. That is jugular vein distension, JVD. So when the right side of the heart fails to pump efficiently, blood is going to be congested in the neck. So with keeping that in mind, jugular vein distension is probably not going to be a symptom that we see in left-sided heart failure. Remember, I told you guys you have to remember how each side works because you're going to see different types of heart failure. So with right-sided heart failure, you will see JVD. So you're going to just want to observe that client at a 45-degree angle, have them turn their head to the left or the right, and look for that distension. So we're going to be listening to lung sounds. So with left-sided heart failure, all that blood is going to back up into the pulmonary system, that pulmonary vein and the lung tissue. So with left-sided heart failure, we're going to be looking for abnormal breathing, advantageous lung sounds. Your patients could present with dyspnea with exertion or dyspnea at rest. They're going to have crackles. They're going to have wheezes. They're going to have gurgles. Left-sided heart failure, you're going to have pulmonary issue. You're going to hear advantageous lung sounds. And then we're going to be looking at sputum. So you're going to ask your patient, do you have a cough? If they say, yes, I do, then you want to know, is it productive or non-productive? Are you bringing anything up? Sometimes they bring it up and they swallow it back down. So they might not be able to tell you what color it is, but you can say, well, how much is it? Are you bringing up a lot? Are you just bringing up a little? And if so, how thick is it? Does it feel thick? Is it thin? And what color is it? Is it clear? Is it yellow? Is it green? Certain pulmonary complications and heart failure will result in different colored sputums and coughs. So then we want to check out their mental status, because if they're not getting that oxygen-rich blood throughout the body, we're not perfusing the brain. The brain is an organ. It needs perfusion. Are they alert and oriented versus are they completely confused and disoriented? They don't know what's going on. They don't know where they are or who they are. We're going to be monitoring for cerebral ischemia. So this is decreased oxygen to the brain. And then when patients don't have proper oxygenation, whether they're alert and oriented or not, this can create anxiety. It's not a good feeling to not be able to breathe. So are they anxious? Are they pacing around the room? Are they getting, are they telling you how scared they are? It could be related to chest pain. It could be related to that impaired breathing. So we can hear crackles and wheezes. So crackles, you can have fine crackles, you can have coarse crackles. Sometimes they also call these rails. These are going to be intermittent sounds that occur when air is going to move through areas that contain fluid. That's what causes the crackles. We classify them in our documentation as fine, medium, or coarse. And then we have wheezes. So these are going to be continuous sounds heard on expiration and also inspiration. So you can hear them both ways, inspiration and expiration. And that's going to happen when that air passes through airways that are constricted. So they can be constricted by swelling. There could be too many secretions in there, or maybe they have some type of a lung cancer. There's some kind of a tumor in there. And then we classify these as sibilant or sonorous. And one thing for you guys to, sometimes rhonchi can sound like crackles or wheezes, and it's going to be hard for you guys because you guys aren't used to hearing abnormal sounds. Maybe some of you have by now. You've been in the clinical setting. I went through my entire nursing school program and never heard an advantageous lung sound until I became a nurse. So don't worry if you're not hearing all these things. And then when you do hear something, don't worry if you can't automatically identify what it is. The important thing is that you can say, this is not normal. Go grab your instructor. Hey, I heard something that doesn't sound normal. Can you come listen with me and tell me what it is? If you hear something that sounds like crackles, you can always ask the patient to cough, because sometimes rhonchi sounds like crackles. So if you have them cough a couple times, usually rhonchi will clear up. Take a listen to them again, and if it's gone, then you know it was rhonchi. If it's not gone, then it's probably crackles. All right, so sometimes we need to measure our patient's pulmonary function. So we will use these pulmonary function tests. So these are used to measure the functional ability of the patient's lungs. We also use these tests to be able to diagnose certain pulmonary conditions that they have. So we have our tidal volume. So tidal volume is the volume of air that is inhaled and exhaled with each normal breath. And I want you guys to have a good understanding of what these are, because you might see them again. Our vital capacity is the maximum amount of air that can be expired after each maximal inspiration. So the amount of air that we expel. Our forced vital capacity, that's the amount of air that is exhaled forcefully and rapidly after maximal inspiration. Our forced expiratory volume is the measurement of your ability to expel air from the lungs. So how well can you get that air out of your lungs? And then our total lung capacity, that's the total volume of air in the lungs when they are maximally inflated. So in patients that have emphysema, they're going to have an increased total lung capacity because they're holding on to a lot of air. They can't get it out. Our residual volume, that's the volume of air left in the lungs after we have that maximal expiration. And then our peak expiratory flow rate. This is going to be our maximum speed of expiration. So how fast can we get air out? So sometimes we need to really try and figure out what's going on with our patient's coronary function. So we have to do certain tests. So we can do something called a cardiac coronary catheterization. We can do a cardiac exercise stress test. So when we talk about an exercise stress test, we'll talk more in depth, but we can have two kinds. So some patients are not adequate for the exercise stress test where you stand up and you actually walk on the treadmill. So we can just give them a chemical medication and they can lay in the bed and we can do it that way. And then we can do an echocardiogram. We can put the patients on a Holter monitor. We can do lung scans. Lung scans are going to show our things in our lungs that can cause issues with our heart. We can do different skin tests, and then of course an MRI. We're going to talk about these. Different laboratory tests we can do. So we can look at serum enzymes and isoenzymes. So we, when our heart is damaged, what happens is our cells in the heart start to break down. When the cells break down, they release certain enzymes into our blood. We perform blood tests, and these enzymes will be elevated if there is heart damage in the patient. So we look at a variety of different things. Some of the enzymes that we look at are CKMB. Sometimes they're elevated with patients that have a heart attack or heart issues, not always indicative. It could be another reason, but we always look at troponins. So troponins are usually they are a sign that the patient has had a heart attack. When we look at these enzymes, we look at them over a period of 8 hours. We usually draw them in sets of 3. Sometimes patients can have different issues where it'll cause their heart to just leak these enzymes, and all these troponins will be elevated. Doesn't always mean a heart attack. So there's always, an outlier to every issue, but usually they're indicative of a heart attack. So we would look at troponins every 8 hours and we would watch them rise. If they continually rise, then that's going to be a positive sign that they've had a heart attack. Sometimes we do watch troponins on a daily level or every few days, but usually the gold standard is every 8 hours for 3 times. We can look at serum cholesterol levels because we know that there is a direct link with high cholesterol and heart issues. So we want to know, does a patient have high cholesterol? So if a patient comes into the emergency room and we think they're having a heart attack, we're giving them things right off the bat. We're giving them aspirin to keep their blood thin. We're giving them atorvastatin, which is Lipitor, to control their cholesterol. We're giving them morphine to control their pain. We automatically give them these things based upon if we think they're having a heart attack. So we want to look at that cholesterol level. We want to look at lipid analysis to see what's going on in the heart. We can do radiography and radionuclide studies. So this is going to determine the size and the position of our heart, and it's also going to look at the condition of our lungs. We can do radioactive chemical elements. So we could do like a nuclear cardiology study. So this is when the patient comes in and we inject medicine through their veins. It goes into their bloodstream, and then we take a series of pictures, and this is used to help look at any kind of damage to the heart. We can also use it to guide the insertion of cardiac catheters, when we place pacemakers, and when we put internal defibrillators in our patient's heart. So sometimes our patient's heart does not work and it doesn't continuously beat on its own. So we'll put a defibrillator in there, which will act to sense when the heart stops beating, and it'll automatically give that shock to the heart and restart the heart again. Then we can do echocardiogram. So an echocardiogram uses ultrasound waves to determining how well that left ventricle is functioning. We can use it to detect tumors. It can also identify certain congenital defects. We see a lot of these in our adults, but also babies when they're born. It can identify murmurs, any kind of problems that we're having in the tissues, those different layers of the heart. We can also do something called a TEE. This is a transesophageal echocardiogram. In the healthcare setting, we say TEE because that is a whole mouthful. This is when the patient, we take a tube with a very small transducer. At the bottom of it, we put it internally through their mouth, through the esophagus, and then we are able to take a series of images of that posterior heart, and then we can see all of the internal structures from the esophagus. It gives us like a superior view, and we can identify any abnormalities. We can do MRIs. So MRIs will give very detailed information about the anatomy of our heart, the function of our heart, how our blood is flowing through our heart, any metabolism, circulatory perfusion issues. Things to think about for your patients to come for MRI. Usually we give them contrast. It can be done without contrast, but it's always going to be more detailed if we give them contrast. So we want to think about their kidney function. So if they don't have kidney function, contrast is not good for them. But sometimes maybe the test is mandatory. So we want to check that kidney function in the morning. The doctor may not remember to order fluids afterwards, or he might not remember that the patient has impaired kidney function. So you would need to say, the patient's getting contrast. Let me see if their BUN or their creatinine are elevated. If they are and you don't have an order for fluids afterwards, you would want to call the doctor. Some patients, if they have severe kidney issues, if they're on dialysis, we'll give them a bolus of fluids. So we'll give them IV fluids rapidly over like an hour before they go, and then we'll give them another bolus when they come back, because we really want to flush out all that contrast. We want to let them know that they might have a flushed feeling when they're having the test done. It can be very loud, so you might want to offer to send your patient with earplugs. And then you want to think about anxiety issues. So you always want to ask your patient, are you claustrophobic? If they say no, it's fine. If they say yes, make sure that they get some type of medicine. If they can't take medicine by mouth, make sure you get something IV. And then you want to make sure they have this medicine about 45 minutes to 30 minutes to a half an hour, 30 minutes to 45 minutes, before they go for the test. Because if you send them down there and they're anxious they're just going to have to come back again. And then if they have to come back again, their appointment's going to get bumped, and we don't want them to lose their spot. We want to, it's important that we see what's going on with their heart. If you're giving them a PO medicine, you want to probably give it 45 minutes to an hour before. You don't want to give it to them as they're leaving, because you know it's never going to take effect by the time they get there. If it's an IV medication, you probably want to hold off as close to the time that transportation comes as possible, because we know IV works faster, but doesn't last as long. And you want them to be able to, an MRI takes about 45 minutes to an hour. So let's see, when we do an electrocardiogram, this is going to look at the electrical currents inside the heart. This is also the EKG. They're used interchangeably. We use color-coded electrodes that are matched to corresponding lead wires that connect to the patient to the recording machine. These electrodes are coated with a thick piece of conductive gel, and then you apply it to the surface of their wrists and their chests. We can do a resting ECG or an EKG. This is performed at baseline, so before their exercise. It's appropriate for patients with impaired mobility. So if a patient has chest pain, if a patient calls out and says, I'm having chest pain, the first thing I'm doing is getting an EKG. So in my facility, we have something called nurse-driven protocols. I can get an EKG on a patient and put the order in without having an order from the doctor. Valuable time is wasted if a patient is having a heart attack and you can't get in touch with the doctor and you need an EKG. So make sure you guys are doing that if that's your policy for your patients. You can do an exercise ECG or an EKG, more diagnostic. It's going to demonstrate heart functions, and it's going to demonstrate any abilities, any abnormalities that happen when the patient is exercising. You can do that ambulatory ECG, which is that Holter monitoring. Usually these are done on an outpatient setting. You'll go to a cardiologist outpatient. They'll give you this, or they'll send it to your house. You put it on, you're going to keep a diary. The patient will keep a diary of their activities, what they're doing, any associated symptoms, and they're going to keep it on for about 24 to 48 hours. Usually they don't bathe with it. Things that we want them to identify. If they got up and they went to make a sandwich at lunch and they felt their heartbeat, they would want to stop, write that in their diary. It's 2 o'clock, I went to make lunch, I had 4 abnormal beats. These Holter monitors can detect dysrhythmias, which are rhythm abnormalities, and they can also detect myocardial ischemia that can occur sometimes during activity or rest. And then we can do that exercise ECG, also called the stress test. So this is where the patient will get on a treadmill, a bicycle, or stairs, and then we have them walk or run or walk up and down the steps, and we gradually increase that speed. The goal of these tests is to increase the heart's workload to reach a predetermined target heart rate. And then we monitor the patients for symptoms. So when their heart works harder, do they become dizzy? Do they get short of breath? Do they have chest pain? Are they complaining of that leg pain because they're not getting that oxygen? Does their blood pressure increase, or does it decrease? Do symptoms occur? And then if the symptoms do occur, then we automatically stop the test, of course, because we don't want the patient to have a heart attack. So these, getting on the treadmill, doing the bicycle, doing the stairs, these are all appropriate for people who can walk, that are functional. For your patients that are not functional, if they have like a broken leg or they just are weak and they can't walk, you would want to do a drug-induced stress test. So these are for your sedentary clients, and this is important. I want you guys to know that. Physical disabilities, severe arthritis, your total patients that can't get up and move. Same thing, it's going to detect compromised blood flow, any kind of coronary artery disease. We're going to give medication to simulate these, that walking on the treadmill and riding of the bike and walking on the stairs. So we're going to use adenosine, also known as adenocard. We're going to use quercetin. These are drugs that dilate that coronary artery, which simulate that exercising mechanism, and it's going to increase the patient's heart rate. So sometimes our patients will have blockages, and they need to have what's called a cardiac catheterization. So usually if they're having a heart attack, they have a blocked artery. We want this to happen very, very quickly. I work at UBMC. We don't do cardiac casts at our hospital, so we always have to send them out. But when we do recognize that they are having a heart attack, it happens very quickly within an hour or two. So we do these in a variety of different settings. They are usually in an operative setting in a hospital. We can do it for, they can place a catheter inside of a peripheral blood vessel. So in your groin, in your arm, in your neck, it will go through the inferior or that superior vena cava and then into the heart. And it's gonna break away that, this is a good picture right here of the stent that they put in. It helps scrape off any of the plaque or any kind of buildup in there, and it's going to open up that artery, that vein, so that blood can get through. Preparation for the procedure. They don't want to take any medications before, unless we've given them medications to control chest pain, like nitroglycerin, things like that. They have to be NPO, nothing by mouth. You want to find out if they have any allergies. Do they have any allergies to iodine, shellfish, radioactive dye, or latex? And then we want to give them IV fluids, of course, because they are going to be NPO and they're not taking anything in. And then we want to tell them that we are going to give them a mild sedative. It's a conscious sedation with a local anesthetic. Post-procedure, your book says that they stay overnight. Patients that come in earlier in the morning, like my mother-in-law had it done, she did it at 5 o'clock in the morning. She was home by 3 o'clock in the afternoon. They really want you to stay 5 or 9 hours afterwards so they can monitor for any adverse side effects and control any kind of unwanted bleeding. So if it happens earlier in the morning, your patients may go home that day. As it starts to get later in the day, they're going to spend the night. Wherever in that groin, that blood vessel, the neck, wherever they go in, you're going to make sure that you have a pressure dressing there. So a pressure dressing is a dressing that is going to do exactly that. It's going to put pressure on that area. Just like when we take an IV out of a patient who is on a blood thinner, we're always going to hold pressure there because they have an increased likelihood of bleeding. This is the same thing. We want to make sure that we control the pressure. We don't want any unwanted bleeding. So as the nurse, important things that you're going to do if they come back to your unit, you're going to be monitoring their blood pressure. A fall in blood pressure is going to be a sign that they are having some type of bleeding. You're going to be doing pulse checks. So your upper and lower extremities, those femoral pulses, the carotid pulses, popliteals, all the pulses. You're going to assess for color, temperature changes in that extremity, wherever they went in and did that cardiac cath. And then you are going to be constantly monitoring that pressure dressing for signs of bleeding every hour for like the first 4 to 5 hours. And then client instructions. You are going to want that patient to keep their extremity straight for several hours. Usually when the post-op nurse calls, she's going to tell you exactly what time the procedure was done and what time they can sit up again and they can start using that extremity again. You want them to avoid any movement. You want them to report any pain that they have, or if they feel any warmth in that site, which would be a sign of bleeding, if they have any sudden numbness or tingling. And then we're going to encourage them to drink large volumes of fluids because we want to get out all that contrast and that dye that we had to put in. So if your patient is not able to drink, you want to make sure that they have some IV fluids because we don't want to cause any kidney damage. They're going to just do normal rest for 3 days. They're not going to be going to work, no heavy lifting, anything crazy like that. They should just be resting. All right, so coronary arteriography. So this is going to determine the degree of blockage in our coronary arteries. We do this by putting, we instill a contrast medium into the arteries. Occlusive heart disease is going to be indicated if one or more coronary arteries appear narrow and they don't fill. So post-procedure, things we're going to want to monitor for. We're going to monitor for any bleeding, any tenderness that they have, if they have a hematoma formation, any infection and inflammation. So we're going to be checking for redness and warmth. We're going to be monitoring their white blood cell count. They are going to be on bed rest for the rest of the day, and we are going to educate them to avoid any kind of flexion or bending because we don't want to start bleeding. We're going to do vascular assessments distal to the insertion site at frequent intervals. Usually it's going to be every 4 to 5 hours, every hour at first, and then as you go on, every 4 hours, every 6 hours, and then they completely discontinue them. You are going to report absent distal pulses to the doctor immediately. So if you have absent distant pulses, cool toes, cool legs, pale or cyanotic arms or legs, these are medical emergencies. You need to let the doctor know right away. You guys need to know this. This could be indicative of a blood clot or an arterial occlusion. And you also want to check for rapid or irregular pulses. It could be some type of internal bleeding. We're having those rapid pulses or some kind of a heart issue. Angiocardiography, this is when we put a radio peg contrast medium into a vein. It'll go through the course of the heart, and then we record it by a series of taking a couple different x-ray pictures. This is going to take a look at the size and shape of our heart chambers, our great vessels, and it's going to determine any congenital abnormalities. Most congenital abnormalities, a lot of them, I won't say most, are determined when we're children, but sometimes they develop as we get older, and we identify them when they're adults. So to have this test, the client is going to fast for 3 hours prior, and we do give them a small sedative and an antihistamine. An aortography is going to detect aortic abnormalities, such as aneurysms. So aneurysms are just simply an abnormal dilation of a blood vessel wall. And it also can detect arterial occlusions. So aortic aneurysms is one of the things it can detect. We use this test by injecting a contrast medium into the patient, and then we take a series of films of the abdominal aorta and the major arteries in the legs. We have peripheral arteriography. This uses dyes and rays to find narrowed or blocked arteries that help supply blood to the legs, and this can help diagnose occlusive arterial disease. We have that TEE. So with a TEE, we use that ultrasound transducer that we talked about that is on a flexible tube that is passed into the esophagus. When the transducer is at the level of the posterior heart, it's going to transmit an image, and it's going to look at the heart. It's going to give us that superior view, and we're going to be able to look at all those internal structures. So the electrocardiogram, I can't talk this morning, or the EKG. So this is going to be that recording of the electrical currents of the heart muscle. What we see over here on the right, that's what you're going to see on the printout that you get. This is what you're going to see on your monitor when you're doing that continuous telemetry monitoring, that continuous cardiac monitoring. These are the images that you're going to see. So we put these color-coded electrodes on the patient's body in various places, the arms, throughout the chest. I'm going to show you how we place them. We put them on the legs, on the wrists, and they correspond to different lead wires that are on the EKG machine. These electrodes, again, are coated with that conductive gel. Each box in this printout that you're going to see, each small box, so you see each little small box in there, each box is going to be worth 0.4 seconds. So we determine if this EKG or their telemetry strip that we pull from the telemetry monitor, we determine if it's normal by measuring certain things on this strip. And we use this 0.4 second for each box as a guide. So the PR interval, we measure that from the very beginning. This first little hump right here, this is called our P wave, okay? So we want to measure the PR interval. So the P starts here, and then our R is going to end over here, the PR interval. So we're going to count each box from where that starts to where it ends, and you can see the two red lines there. That the normal PR interval is anywhere from 12 to 20 seconds. So if your number falls in between 12 and 20, then we know that that is normal. The QRS complex, we're going to measure that from the beginning of the Q So this little line right here, we have the Q. All the way at the top here is the R, and at the bottom is the S. So we call this the QRS complex. And then we have the QT interval. So the QT interval is going to be measured from the Q, which is right here, all the way to the end of the T wave. So this is our T wave right here. So if we were measuring, we would start at this little dot and go all the way over to here, okay? We're going to talk a little bit more about that, but that's just a general idea. So each little box is worth 0.4. All right, so now we're going to talk about infectious and inflammatory disorders that can affect our patient's heart and their blood vessels. So rheumatic fever and rheumatic carditis, you guys have probably heard about this at some point in your lifetime. So rheumatic fever is a systemic inflammation disease that follows a streptococcal infection in our throat. So strep throat. A lot of you have probably had strep throat. When strep throat isn't managed, it causes rheumatic fever. Rheumatic carditis is an inflammatory cardiac manifestation of rheumatic fever. So two different things there. The cardiac structures are affected are the heart valves. So that mitral valve particularly, that's the mitral valve there. So I showed you a picture very early on of what the mitral valve looks like, and it does not look like this. You can see how torn it is. We call this vegetation. So the mitral valve gets vegetation on it, and then the heart does not work properly. So these cardiac structures that are going to be affected, that mitral valve, the endocardium, the myocardium, and then the pericardium. So what happens with rheumatic fever and rheumatic carditis? Well, the antibodies originally are formed to help destroy that group A strep. It's going to induce inflammatory symptoms of rheumatic carditis. The antibodies mistakenly cross-react against proteins in the connective tissue of the heart. It can also happen in our joints, our skin, and our nervous system. This cross-reaction is going to cause damage to the valves and inflammation in all the layers of the heart, so pancarditis. So what kind of assessment findings are you going to find in your patients? So patients that have acute rheumatic fever, they're going to present with a mild fever. They're going to have a rapid heart rate and an abnormal rhythm. So we know an abnormal rhythm is not going to be lub-dub. It's going to be lub-dub, lub-dub, dub, lub-dub, lub-dub, dub, lub-dub, dub. It's not going to be normal. You're going to feel that in your pulses. You're going to be able to hear it when you auscultate. They're going to present with this red spotty rash on the trunk. Okay, this is what it's going to look like. But it's going to disappear quickly. And when it does, it's going to leave these irregular circles on the skin. You're going to see swollen joints. Those joints are going to be warm, they're going to be red, and the patients are going to complain that they are painful. Cardiac complications, so consequences of this rheumatic fever that are untreated. So patients can develop heart murmurs. Remember, they sound like those swishing sounds. And then they can also develop a pericardial friction rub. You can have heart failure, they're going to have a rash, or they can also have chorea. So these are jerky, involuntary movements. So this is a good picture. We see this very commonly in small children. It can also happen in adults. So I worked with a woman many years ago before I was a nurse, and her husband got sick and started having all these issues, and he had all these lesions on his liver, and they thought that he had cancer, and they basically told her that there was really nothing that they could do for him because he had so many lesions and that it had progressed so far. So they sent this gentleman home on home hospice, and something just didn't set right with his wife. She didn't have any kind of medical background, but he stayed on hospice for 3 weeks. They were giving him medicines, the Ativans, the Haldols, all them to keep him unconscious. He was basically sleeping, but something just didn't set right with her. So she wound up taking him back to the hospital again. She put him in the car, took him to St. Joe's, just said, I don't think something's right. St. Joe's took a look at him. Well, long story short, He didn't have cancer. He had rheumatic fever that had been left untreated. He had had strep, never went to the doctors. It turned into rheumatic fever. It left all these lesions on his on his liver. They gave him antibiotics. He stayed in the hospital for about 2 weeks. He lived like another 35 years after that. So yeah, rheumatic fever can cause these issues. So it's going to affect the heart. You're going to see that erythema. You're going to see, sometimes you'll see these subcutaneous nodules. You're going to see an elevated sedimentation rate. Your C-reactive proteins are going to be high because those are indicative of inflammation. Those jerky movements that we're talking about, you're going to see them in your wrist, your legs, and then that arthritis. Those joints are going to be painful and warm. So this is what a normal mitral valve looks like here on the left. And this is a rheumatic mitral valve. So you can see how closed it is, which is caused because of a stenosis. So you can see the damage that rheumatic fever does. So diagnostic findings, we're going to look at that SED rate. We're going to do an ECG. We're going to look at C-reactive proteins. These are going to indicate inflammatory responses. We're going to do an electrocardiography, an echocardiography. These are going to show structural changes in those valves. It's going to show any change in the heart and the contraction ability of the heart. How are we going to treat these patients? So we have medical and surgical management. So we're going to give them IV antibiotics. We want to get rid of this. So we're going to give them penicillins, vancomycins, and zithromax. Surgery, if they have something that can develop called constrictive pericarditis and they have damage to the heart valves, they're going to need surgical interventions. We are going to administer aspirin because we want to do clot prevention. So anytime your heart has an abnormal rhythm, you are at a high risk of developing a blood clot. If the blood is not perfusing the body and coming out in a regular manner, the blood can pool. If the blood's pulling, you're at a risk for a blood clot. So your patients that have AFib and aflutter chronically, they are always on blood thinners. So we want to make sure they have aspirin. We're going to give them steroids because we want to reduce that inflammation. And then we're going to give them prophylactic antibiotics. So before invasive surgeries that are going to predispose the patient to bacteremia and the recurrence of any endocarditis. So this is going to be a lifelong thing, not just initially. It's going to be when they go to the dentist. If they have any surgery, these patients need to understand that they are going to have to take prophylactic antibiotics. So that's important. You guys need to know that. So nursing management, what are we going to do? Well, we're going to give that prescribed drug therapy. We're going to make sure that we're giving those IV antibiotics on time because they need them. You want to give these patients a probiotic. So you want to advocate for the patient if the doctor doesn't order one, because anytime we're giving our patients a lot of IV antibiotics or even PO antibiotics, we know that they can get C. diff. So we don't want that to happen. So we can ask the doctor to prescribe a probiotic, and we can also encourage the patients to have yogurt in their diet. We're going to monitor for therapeutic and adverse effects. So we're going to educate the patient about any side effects they may have from the medication. We're going to make sure they're not having those side effects. And then we are going to monitor for those white blood cell counts, right? We're going to make sure that those values are trending down. We're going to look at that C-reactive protein, that SED rate. We're going to make sure those numbers are coming down, which is going to indicate that inflammatory response is starting to diminish. We're going to do diversion activities. So we want these patients to rest. We want them to do things that require minimal activity. So we probably don't want them to get a shower. We want to encourage them to just sit on the side of the bed. We can help get them set up for their baths. We really don't want them walking around the halls. We want them to be on bed rest, keeping their activity at a minimum. Focused cardiac assessments. We're listening to those heart sounds. probably more than once a shift, at the beginning of the shift, and then maybe towards the middle of the shift, and then again at the end of the shift. And then we're going to make sure that we give them any prophylactic antibiotics that they may need. And we want to educate them about the fact that they're always going to need those prophylactic antibiotics. So this is just the process of that rheumatic carditis after that strep A. This is in your book. You guys can look in your book and see that. So the next thing we're going to talk about is infective carditis, which is formerly called bacterial endocarditis. You might still hear this in the hospital setting. It's used interchangeably. So this is inflammation of the inner layer of our heart tissue. So patients get endocarditis because of an infectious microorganism. Initially, it was considered an autoimmune response because no microorganism could be isolated from the blood or from any type of a blood culture. So they thought it was an autoimmune response. This can occur subsequent to having rheumatic carditis. So there are microorganisms that include bacteria, streptococci, staph, and fungi. These can all cause endocarditis. So what causes it? It can be prolonged IV therapy. It can happen if we insert cardiac pacemakers, if we do cardiac catheterizations. Some patients that have a Foley from an infection that can go to their heart. We see this a lot in IV drug users. We can see it in non-rheumatic disease, and then we can also see it in patients that have artificial heart valves. Infective endocarditis usually affects the left side of the heart more than the right, and the mitral valve is usually the most common location. One thing that happens with infective carditis is that those vegetations that I showed you a couple slides back, they can break off. When they break off, they get into our circulatory system, they form emboli, and then they can occlude small blood vessels, and then it can interfere with our organs' blood supply. So that's a dangerous side effect. So acute assessment findings. So what are we going to see acutely? Our patients are going to have fever. They're going to have chills. They're going to complain of muscle aches and joint pain. Subacute infections. So these are going to progress over weeks to months. Those manifestations are going to be more vague. They might say they have a headache. They might just complain of malaise. They might just be tired. They might even complain of sleep disorders like insomnia. So those are very vague. As the condition starts to advance, our patients are going to develop what we call Osler nodes, and these are going to develop on the pads of their fingers and their toes. This is important. You guys need to know this slide. They are going to get what we call splinter hemorrhages. These are black longitudinal lines that we see on the nails. It can be on the fingernails and the toenails. They're going to develop something called Janeway lesions. These are very small, painless, reddish bluish macular lesions that are found on the palms of our hands and on the soles of our feet. These patients also develop Roth spots. These are white areas in the retina surrounded by an area of hemorrhage. They're also going to get petechiae. Petechiae is very tiny, reddish hemorrhagic spots. We can see these on our skin, anywhere on our skin, and we can also see them in our mucous membranes. Some of these patients will get enlarged spleens, and they will also develop heart murmurs. This is important. I want you guys to know this slide. So this up here is the Osler nodes. These are the Janeway lesions. There's those splinter hemorrhages and those, what you would see on the retina there. And these all came from your book, so you can read more about those in your book. So we are going to see changes in the tissue with endocarditis. So this is a good picture here of all the layers. So this middle part here is your myocardium. You have your pericardium here. This is your fibrous pericardium. It goes around that pericardium. And this is the area of the myocardium, which is in the endocardium, sorry, which is inflamed. And you can see right here how puffy it is and how filled it is with infection. So diagnostic findings, and this is a good picture of that mitral valve and all those vegetations and how some of these can break off. So what are we going to see? What diagnostic findings? Your patients can present with anemia, and they can also present with leukocytosis. So what you're going to do is you're going to do blood cultures. So whenever we take blood cultures, you're going to take a series of 3 from different areas over 1 to 24 hours. So usually when we do regular blood cultures, we do 2, 1 in each arm, or 1 in 2 of them, but 1 in each, a different area. These are going to be a series of 3 over 1 to 24 hours. The doctor will usually tell you, I want them over 6 hours, I want them over 8 hours. They will decide. We're going to do that TEE. When we do that TEE, we're going to see vegetations. We're going to see that those valves are not functioning properly. And we're going to see that the ventricles are not pumping appropriately. And then we're going to do that ECG or EKG, and that's going to reveal abnormalities in our heart rhythm because we're having problems with those valves and those ventricles. So our heart's not going to beat normally. So medically and surgically, what are we going to do? We are going to give high doses of IV antibiotics. These usually last 2 to 6 weeks. So something that's common that we will see, we don't want to keep our patients in the hospital for 2 to 6 weeks. So we will give them a PICC line once they're stable, and we will send them home with home care nursing. They'll have a central line or a PICC line, and they will continue that IV antibiotic therapy at home because they need it for so long. We want these patients to have bed rest. We don't want them up walking the halls. They're not getting showers. They are minimizing their activity. They are staying in bed. Once their condition improves, we slowly give them back some privileges. So we might start letting them go to the bathroom, and then gradually as they continue to get better, they're going to have more increased activity. PT and OT will probably not be coming to work with them and getting them walking around the hospital. So you as the nurse are going to want to encourage them to do different exercises in bed, do their foot pumps, move their arms, promote that mobility that you can help them with. And then sometimes they need surgical interventions and they need valve replacements. So from a nursing aspect, what are we going to do? This is important. We're going to limit that activity. You guys need to know this. You're going to assess for changes in our patient's weight. We're going to be monitoring that pulse rate, and we are going to be monitoring their heart rhythm. So these patients are probably on a continuous monitor. We are going to note any new symptoms they didn't have before to the doctor. We're going to make sure we are giving those antibiotics on time, make sure that they have a probiotic on board, teach them about having yogurt with their lunch, their breakfast, their dinner. And then we're going to make sure we are doing that client teaching about the lifelong use of antibiotics. So anytime these patients have surgery, if they go to the dentist, they're always going to have to take that prophylactic antibiotic first. So education is important. So myocarditis. So this is inflammation of the myocardium. So remember, the myocardium is that muscular layer of the heart. So what causes myocarditis? It can be a viral, a bacterial, a fungal, or a parasitic infection. When we see this in the United States, usually it's because of a viral infection. Those are the most common. So this is our Coxsackie viruses A and B, influenza A and B, measles, mumps, and then Epstein-Barr virus. We do see these in patients with chronic alcohol and cocaine abuse, patients who have had radiation therapy, certain autoimmune disorders will cause this, and then patients that have bulimia. Usually these patients use what's called syrup of ipecac, which is used to help them vomit, so they don't have that caloric intake, and then it can cause myocarditis. And then it causes damage like viral myocarditis. So what assessment finds are we going to see? So your patients are going to complain of sharp stabbing or squeezing chest discomfort. This can resemble an MI, so you're going to have to rule out an MI. But when these patients sit up, it's going to help relieve their pain. So that's one indicator that it might not be an MI. If it's an MI, nothing's going to change the pain. They might present with a low-grade fever. They're going to have tachycardia. They're going to have dysrhythmias. They might be dyspneic, so short of breath at rest or with exertion. They're going to complain that they're tired. They're going to have cyanotic skin changes. So look at that picture right there. We can see they have cyanosis right there on the end of their fingertips. They have that bluish purplish color. They're going to have crackles when we listen. They are going to have an S3, which is indicative of that gallop, right? A galloping rhythm. And if the heart's pumping activity is impaired, we might see neck vein distension, so that JVD. We might see ascites, which is when the abdomen gets really swollen. Those patients look like they're pregnant. We might have peripheral edema. So when we have that peripheral edema, that's going to be an indicator of right-sided heart failure, right? We said with left-sided heart failure, all of that fluid's going to back up in the lungs and cause those lung issues. Well, if we have right-sided heart failure, all that blood's going to pool and it's not going to get back to the right side of the heart. So this shows you the tissue changes that we see in myocarditis. So this is that inflamed myocardium. You can see up here how red it is compared to the bottom. And that myocardium right there is that middle layer in between the epicardium and the endocardium. And these images I got them all from your book, so you can always refer back to your book. So what kind of diagnostic findings will we see with myocarditis? Well, our white blood cell count is going to be slightly elevated. So it might not be 23 or 25. It might be 15. It might be 17, slightly elevated. Our C-reactive protein is going to be elevated. Remember, that's an indicator of inflammation. So that's going to be high. We're going to do an ECG. That's going to check for abnormalities. You might see abnormal arrhythmias. We're going to do a chest x-ray. This could show fluid in our lungs. It could also show that our heart is enlarged. We're going to do that echocardiogram. This is going to identify any structural abnormalities. We're going to do that radionuclide study. So this is going to reveal that myocardial wall enlargement. And then we can also take a biopsy and send it off, and that will give us a definitive diagnosis of myocarditis. So medical and surgical management. Patients that have myocarditis are also going to be on bed rest. We're also going to restrict their diet. We don't want them to have a lot of sodium in their diet. We're going to put them on cardiotonic drugs. An example of one cardiotonic drug is digitalis. And eventually, if we can't control these symptoms with diet and medication, they eventually will need a heart transplant. So nursing management, what are you guys going to do? You're going to monitor their cardiopulmonary status. You're going to make sure that they're not developing heart failure. So what do you think you guys would check if you are looking for heart failure? Remember, it's right side of the heart. So what kind of symptoms are you going to look for in your patients?
Jugular vein distension. Edema.
Very good. Edema. Where will you see that edema?
Peripherally.
Do you think it'll be pitting or non-pitting?
Pitting.
Pitting. Very good, Sung. And what do you think these patients might be at risk for if that blood is pooling in the extremities?
Clotting.
Yes. Very good. Good job. You're also going to monitor their vital signs. They're going to be on strict I's and O's because we're worried about them holding on to fluid. So we're going to be doing daily weights. We need to make sure, because they might retain fluid and because of the heart failure, that we're doing strict I's and O's. Everything that they're taking in, everything that they're putting out. With that being said, this is something that you can dictate to your CNA, to your tech. You are ultimately responsible for it. The doctors are going to look at these daily weights and their intake and output and determine what medication changes they're going to make. So you need to make sure at the end of the day that there is adequate output. In my facility, our policy is that we document I's and O's every 4 hours. So you need to go behind your tech and behind your CNA, make sure that these amounts are in there. And if they're not, you need to make sure they're putting them in, or you have to put them in. You're going to listen for those lung sounds. If they're having issues, you're going to make sure you elevate the head of the bed. make sure that they're sitting straight up. It's going to increase that good airflow into the lungs. And then we're going to want to monitor their oxygen levels, that SpO2. Next, we're going to talk about cardiomyopathy. So cardiomyopathy is a chronic condition characterized by structural changes in the heart muscle. It's a chronic condition. So we have 3 types. This is an important slide. You guys need to know this. The 3 types are dilated cardiomyopathy, which is the most common, hypertrophic cardiomyopathy, and restrictive cardiomyopathy. That is the least common. So with dilated cardiomyopathy, what happens is the cavity of the heart becomes very stretched. With hypertrophic cardiomyopathy, the muscle of that left ventricle and the septum begins to thicken. And then as it thickens, it becomes hypertrophic. It gets enlarged. And then that restrictive cardiomyopathy, which is the least common, this is when that heart muscle stiffens and it interferes with the ability to stretch and fill with blood. So patho and etiology, this is when the heart muscle loses the ability to pump blood efficiently. So the heart is not going to pump efficiently. You're not going to get all that oxygen-rich blood to your organs, your kidneys, your liver, your peripheral extremities, your brain. So if you know that you're not getting that perfusion, that is going to tell you what things you're going to want to monitor, what abnormalities you think you're going to see. So your kidney functions, your liver functions, your mental status, these are all the things you're going to check, your peripheral pulses. So your assessment findings based upon which type of cardiomyopathy your patient has. So if your patient has dilated cardiomyopathy, they're going to have dyspnea on exertion and when lying down. They're going to be very fatigued. Their legs are going to be swollen and they're going to have palpitations and chest pain. If they have hypertrophic cardiomyopathy, they're going to have syncope or near syncopal episodes. So they're going to be saying that they're dizzy. They feel like they're going to pass out or they are going to pass out. So these patients are going to be on high fall risk precautions, right? Bed alarms, red socks, red bracelets, signs, the whole 9 yards. They are also going to complain of being fatigued. They're going to be short of breath. They're going to say that they have chest pain. They also could be asymptomatic, depending on how bad the situation is. And then they're going to have, if they have restrictive cardiomyopathy, they're going to have exertional dyspnea. So at rest, they're going to be fine. They're not going to have short of breath. They're going to have that dependent edema in their legs. They're going to have ascites. Remember, ascites is that fluid in the abdomen. They're going to look like they're pregnant. And they're going to have hepatomegaly. With this is where your liver gets large. So you guys need to know the differences between the 3 of them, what's happening and what you would see in your patients, okay? Diagnostic findings. So we're going to do a chest radiograph. We're going to do an ECG. We're going to do an echocardiogram to look at all those inner structures of the heart. We might also do a cardiac MRI, and then they might also need a cardiac catheterization. Medical management. So for medical, the doctor's going to prescribe diuretics. Why? Because we need to pull that fluid off, right? That blood is pulling. It's a right-sided heart issue. We're going to give digitalis, which is one of those cardiotonic meds we talked about. We're going to give antihypertensives. We're going to give anti-dysrhythmic medications because we know the heart's not pumping effectively, so we're going to see arrhythmias in our patients. We know that that blood is pulling. These patients are at risk for developing blood clots, so we're going to give anticoagulants. Corticosteroids, right? We said that they're going to have inflammation. Corticosteroids are going to bring down that swelling. We're going to have that dietary sodium restriction. Surgically, if that's necessary, they might need a pacemaker. They might end up with a defibrillator. Then they might have a ventriculomyomectomy. That's a mouthful. That is removal of a thickened myocardial muscle from the septum. And then they would transplant, they would move it and put in another one. So nursing management, what are we going to do? We want to know their medical and their family history. We want to do a physical examination on these patients. We're going to be listening for irregularities in the heart. We're going to be listening for advantageous lung sounds. We're going to be checking vital signs. What is their heart rate? Is it in normal limits? What is their oxygen level? What is their blood pressure? Listen for those advantageous lung sounds, heart sounds, irregular, tachycardia. If your patient is not on telemetry monitoring, they should be. Go to the doctor and say, look, we need to put a monitor on this patient. We should be monitoring their heart rate. You're going to be checking those pulses, that peripheral edema, because they're going to have swelling because of that right-sided heart, is not working and that blood's going to pool. They're going to have abdominal enlargement because of the ascites. And we're going to be monitoring their oxygen level. So we might see that their oxygen is fine. It could be worse when they're laying down, and then when they sit up, it's better. It could be fine when they're sitting down, but then it decreases when they're walking. So there could just be some variabilities with their oxygen. Cardiac monitoring, we said that, monitor the O2. These patients are going to need emotional support. So we know anytime that a patient is sick, they need emotional support. Whenever we have any type of issue that affects a patient's ability to breathe, it scares them. It's the worst feeling, not being able to breathe. So they might need something for anxiety. They need a lot of emotional support. And then we want to encourage, this is important, you guys need to know this, we want to encourage these patients that they want to get their pneumonia vaccine and their yearly influenza vaccines, because we want to avoid any type of pulmonary complication that can compromise their cardiopulmonary functioning. Important to know. All right, so we have pericarditis. So this is inflammation of the pericardium. It can be primary or it can be secondary. So when it occurs primarily, it develops independently of any other condition. It just happens on its own. Secondary, it's going to develop because the patient has another condition. That other condition could be endocarditis, myocarditis. They could have had some kind of chest trauma. Maybe they were in a car accident. It could be because of a myocardial infarction, a heart attack, or sometimes we see it post-cardiac surgery. It can happen with or without infusion. So infusion is that accumulation of fluid that occurs between those two layers of tissue. There's a misspelling, sorry. 2 layers of tissue. So when we get that effusion, we get that accumulation of fluid. That can lead to 2 things: a cardiac tamponade and a pulsus paradoxus. So a cardiac tamponade is an acute compression of the heart. This can be fatal. If your patient starts to show signs of this, you need to contact the doctor immediately. There also can be pulsus paradoxus. So this is when you have pericardial fluid which fills in the space that's needed to accumulate with blood. So blood can't get in there. Also an emergency situation. So how you would determine if your patient had a pulsus paradoxus, it's going to show when you do a blood pressure, you're going to see a difference of 10 or more between that first corticough sound that you hear in the systolic blood pressure during expiration, and then the first that is heard during inspiration. There's more about this in your book if you want to read about that, but that's how you would determine if a patient had it. Assessment findings would be the patient's going to have a fever, they're going to have malaise, they are going to report that they have heaviness in your chest. Might not be pain, it might just be described of heaviness because of all that fluid. They're going to have precordial pain. Moving and breathing might worsen the pain. So when they get up and go to the bathroom, they might say, oh, it hurts worse. When they reposition in bed, sitting upright and leaning forward will relieve the pain. This is an important slide. You guys need to know this. So these patients, when you come in the room, they can be sitting straight up, or sometimes they're going to be bent over with their elbows on their knees. That's going to help relieve that pain. They're going to have that pericardial friction rub, and then they're going to have severe hypotension, because remember, that fluid is accumulating in that area that normally fills with blood. So that oxygen-rich blood is not getting there. Their circulating volume is going to be lower. So they're going to have hypotension. So these are the signs and symptoms of a cardiac tamponade. So they're going to have syncope. They might have anxiety. Some patients describe this as like they really can't even explain how it feels. It's just kind of described as like impending doom. They feel like something bad is going to happen. They might have prominent neck veins due to that elevated venous pressure. Their heart sounds can be muffled. That pericardial compression is going to happen because of that fluid-filled pericardial sac. They might have a cough due to that compression of the trachea and that bronchial expanding sac. They're going to have dyspnea and decreased cardiac output, and then they're going to have that paradoxical pulse. And I got this from your book, so you can find this in your book and read more. So pericarditis is that tissue change in the that we see. Normally the epicardium and the pericardium slide over each other easily because they're lubricated by a small amount of fluid. A thicker material replaces this fluid in pericarditis, and you can see it right there, how inflamed it is, and that swollen area right here, how red it is. So diagnostic findings. So our ST segment, right, of our EKG is going to be elevated. Your chest X-ray is going to show enlargement of the heart. Your echocardiogram is going to show a wide gap between the pericardium and the epicardium, indicating that that space is going to be filled with fluid. Your white blood cell count is going to be elevated, and your sedimation, your ESR rate is going to be elevated, which is going to signal inflammation. So medical management, remember we said we have to rule out an MI first. These patients are also going to be on bed rest. We're going to give them analgesics to help with that pain, that chest heaviness. We're going to give them antipyretics because they have a fever, NSAIDs, and then corticosteroids because of that inflammation. So if they need surgery, there's a couple different things they can do. They can do a pericardiocentesis. This is where they do a needle aspiration of that fluid in between the visceral and the parietal pericardium. We can do a pericardiostomy. This is where they make a surgical opening in the pericardium, and it helps to drain all of that fluid out. We can do a pericardioectomy, which is where they actually remove the pericardium. And then we can do a decortication, which is where we remove the surface layer of that pericardium, that outermost layer, but not the whole thing. So nursing management, we're going to do that pain assessment, monitor their pain, make sure we're giving them pain medicine, because they're going to have pain related to the inflammation and because they don't have proper myocardial perfusion. We're going to make sure we're listening for those abnormal lung sounds. We're going to assess for JVD. We're going to assess for decreased cardiac output. So how can we tell if a patient has cardiac output? What can we look at?
Low blood pressure and increased heart rate.
Very good. What would we see in our pulses?
There'll be rapid pulse.
Could be rapid. As we check our lower extremity peripheral pulses, they're going to be diminished because that blood flow isn't strong enough. Very good. So a persistent cough, dyspnea, they might faint. They might report anxiety because they're not breathing properly. And then we're going to see changes in the pulmonary functioning. So interventions, we are going to monitor for tachycardia. They probably should be on a cardiac monitor, right? We're going to monitor for that pulsus paradoxus, which is that large decrease in systolic blood pressure and pulse during inspiration. We're going to look for that JVD, cough, syncope. If they have a pericardiocentesis, we're going to want to monitor that site. It's going to be covered with a sterile dressing. You're going to make sure you're monitoring that dressing at least every hour at first for 4 to 5 hours. You're going to make sure that there's no leaking fluid or any blood. You want that dressing to be clean, dry, and intact. We do this because the rationale is compromised skin and the underlying tissue is going to create a potential for blood and fluid loss, as well as we know it's a breeding site for bacteria, and we don't want to cause another infection. And then evaluation. Your patient is going to report to you that their pain is relieved. They're going to see that their vital signs are stable, which is going to be indicative of that good cardiac output. You're going to have normal cardiac rhythm, and that cardiac tamponade is going to be managed. So do you know how to assess for a pericardial friction rub in your patient? So you can just tell your patient to hold his or her breath, and then you're going to auscultate their heart sounds. A pericardial friction rub does not appear when the patient's breath is held. There is a video here you guys can click on when you are studying later, and it will show you how to do it, and it'll let you hear what it sounds like. So we talked about that pericardiocentesis. So this is, they have a central venous pressure monitoring line, which is going to be open in case they have to give any type of emergent drugs if the patient starts to decompensate while they're doing the procedure. You are going to make sure that you have your defibrillator and your resuscitation equipment ready. With a pericardiocentesis, they're going to use a syringe and a needle. They're also going to have an ECG attached, and they're going to use small circles which indicate the areas that they are going to do that pericardial incision or that aspiration. So they're going to mark it on the patient where they want to go in, and then they're going to use an ECG to monitor their heart while they're doing this procedure. Thrombophlebitis. So thrombophlebitis is inflammation of a vein accompanied by a clot or a thrombus formation. A DVT, it could also turn into a PE, a pulmonary embolism. Clots are more commonly seen in patients in the veins of the deep lower extremities. So we call that a deep vein thrombosis, a DVT. We can see thrombophlebitis anywhere in the arms, anywhere in the body, but we most commonly see them in the lower veins, and we refer to them as a DVT. They are at risk for developing a pulmonary embolism. So this is a thrombi that forms above the popliteal vein of the leg. And when this happens, it's at a very high risk for moving. It enters into the circulation and it'll go into your pulmonary circulation. These can be fatal. What happens for these to develop is the inner vein becomes irritated or injured somehow. You have that large, rapid congregation of those platelets. They all clump together because they're trying to heal that site, and they form a clot. The clots get big and they interfere with blood flow. They either occlude it altogether or very little blood can get by. It interferes with blood flow, causes congestion of that venous blood distal to the clot. There is something called Fairchild's triad. So this would be, a patient would have this if they had 3 things: venous stasis, which is where the blood's not moving, it's pulling; altered blood coagulation; and trauma to the vein. So if your patient has all 3 of these, this is going to predispose your patients to thrombosis and thrombophlebitis. So if your patient has this, you want to be implementing things to prevent them from getting these blood clots. So your assessment findings, they are going to complain of discomfort in that extremity that's affected. So they could just say pain, they could say that it's tightness, anything like that, swollen, it feels full, numb. you're going to notice calf pain that increases on dorsiflexion. So this is called a Hohmann sign. So we teach this in nursing school still, but it's not something that you want to have your patient do if you think that they have a blood clot in their leg. So if you were to have them put their legs out and then do dorsiflexion, bring their toes back, if they have pain, it's an indicative sign that they might have this blood clot. But if you do that, it can also cause the clot to dislodge. So in nursing practice, we don't usually have them do that if we think that they have a blood clot. They will have heat and redness and swelling on that infected extremity. Their capillary refill will be less than 2 seconds because they're not getting that good cardiac output and it's not getting to the extremities. They can have a fever, malaise, fatigue, and then anorexia. They just might not feel like eating. So how are we going to diagnose thrombophlebitis? Well, we're going to send our patients for a Doppler ultrasound. This can detect any type of venous obstruction. We can do a venography, which is where we put in a dye. It's going to run through the venous system and it's going to indicate a filling defect in that area where the clot is. We can do an IPG. So this is the preferred test for diagnosing clots. This is where a sensor records blood volume in the arm or the leg before and after inflating a blood pressure cuff to stop the venous flow. If a blood clot is present, the blood volumes are nearly the same because the clot impairs venous activity. Medical and surgical management. We want to get our patients up and walking, right? We want to ambulate them. We want to prevent them from getting these blood clots. So early ambulation, getting your patients to the chair, encouraging them to walk. We can do compression bandaging. We can do anticoagulant therapy, TEDs, SEDs, continuous warm wet packs. Not something that I've ever done in the clinical setting. It is some evidence-based practice. They talk about it in your book. It can improve circulation. It can ease the pain and help decrease that inflammation. And then if they need surgery, so they might need a thrombectomy. So this is where they go in and they actually surgically remove that clot. They can do a ligation, which is where they go into, they do a surgical procedure and tie those veins, which will prevent the pooling of blood. And then they can put in a vena cava filter. So this is like a little umbrella-like filter that they insert, and it's going to trap those emboli before they ever reach the heart and the lungs, so that we don't have to worry about a patient getting having a PE. So what are we going to do as nurses? Well, we want to assess the patient's history of blood clots. Do you have a history of blood clots? Well, if you do, then you know what implementations you want to provide. So you want to say, you want to identify any risk factors. Do you have AFib? That's a major one. You're going to see this. So many patients have AFib. Well, you know if they have AFib, they have to be on a blood thinner for lifelong treatment. It's not even an option because their heart rate is never regular and they're always going to be at risk for developing a blood clot. So you want to make sure that they have anticoagulation. Have they had any recent surgeries that would increase their risk of developing a blood clot? Are they obese? Increases their risk. Are they using contraceptives? That increases their risk of developing a blood clot. Do they have that Hohmann sign? Could be indicative of a blood clot. Pain or tenderness in that calf. Do they have any redness, any swelling, any warmth? Check that capillary refill. And are they complaining of any sudden chest pain and dyspnea? These can be signs of a PE. I remember my sister-in-law is a baby nurse, and she was taking care of a patient who was on bed rest because she kept going into labor, and they needed to, I think she was in the hospital for like 6 weeks period, but she wasn't getting out of bed. And she only had 2 weeks to go. And she had her husband there. This was pre-COVID times. And she had called out to my sister-in-law and she was like, something's wrong. She was like, I'm just so short of breath all of a sudden. And I don't know what the problem is. And I'm having chest pain. So they gave her a couple different medicines, never took her down for an x-ray. I don't know why. Because when your patient starts telling you they have chest pain and trouble breathing, that's the first thing you want to do. You want to make sure they're going for a chest x-ray so you can rule out a PE. So they said that the doctors came and saw her and they said, well, let's watch it and see if it gets any better. Well, all of a sudden the husband came out. She just completely lost consciousness and she died. She died. They did get the baby out. The baby was able to live, but the mom died. She had a PE. So you need to listen when your patients say things. So when you think chest pain and shortness of breath, you should automatically think this patient's going for an x-ray. And if the doctor doesn't order one, you should say, do we think we should get an x-ray for this patient? So then interventions, we are going to provide analgesics for any pain they have. We are going to encourage early ambulation. I cannot stress that enough. You need to get your patients out of bed. Get them to the chair at least. Have them sit up in the chair. Encourage them to do ankle pumping exercises if they can't be ambulatory. Make sure if they're not ambulatory, you're putting them knee or thigh high compression stockings on, those TEDs, your SEDs. We can give them anticoagulation therapy, so heparin or Lovenox. So what usually happens is that there's a variety of these interventions we can do. Usually in the emergency room, the doctors evaluate them. They look at things on a scale and they decide how at risk they think the patient is, and then they're going to determine what level of anticoagulation therapy they're going to have. Because some people will get Lovenox, some people are going to be heparin, just depends. Deep vein thrombosis, this is when we see that accompanying pitting edema. You're going to get that swelling in there. You can see in here where the blood clot is. They're showing you a close-up there. You know that blood is not getting through there because that clot is there. That blood's going to pool because that blood can't get back to the heart, and it's just going to sit there and it's going to be pitting. It is so easy to get a blood clot. You can go on a flight from here to Florida, be completely healthy and get a blood clot just on a 2-hour flight from not moving. So imagine how susceptible your patients are who sometimes don't move for days, and people do not get them out of bed. I see it all the time. All right, so what are we going to do to assess for a DVT? We're going to look for pain and ask them if they have tenderness. That's one of the things I always do I might not do it all the time in my 20-year-old who came in because they have a bowel obstruction and they're getting up. But in my older patients or patients that are not moving, I squeeze the back of their calves. Do you have any pain there? I do it every time. I'm very good about it because I know how susceptible these patients are. Pain and tenderness in the calf, especially on that dorsiflexion. One calf can be larger than the other because that's the one that's going to have the blood clot, and then greater localized warmth than on that unaffected extremity. So you're checking measurements, you're comparing extremities, checking for warmth and redness. So we did say we could do that surgical procedure and put in that vena cava filter. So this is a permanent implanted filter. It's an umbrella-like filter that allows the blood to circulate to the lungs, but it's going to trap those blood clots before they get into that pulmonary circulation. So you can see right here in the inferior vena cava, this is right where they put that filter. So any blood clots that go through are going to just go in there. I think these are not good forever. They have to be replaced. Don't quote me. I mean, you're not going to be quizzed on this, but I think it's 7 to 10 years that they're good for, depending. Some of the newer ones are good longer, but this is not something they're always going to have because they're going to fill with blood clots, and eventually the blood flow is going to be impeded for them. So they do have to be monitored and they do have to be replaced. So peripheral vascular disease, PVD. So PVD is a condition that affects the blood vessels that supply oxygen to our lower limbs, peripheral. It's a circulatory problem in which our arteries become narrowed and our blood flow is reduced to our limbs. Peripheral vascular disease is a generic umbrella term, okay? This describes a lot of different types of circulatory diseases. PAD, which is peripheral artery disease, is one specific disease that falls under that umbrella of PVD. It is peripheral artery disease, only affects our arteries, and it's primarily the arteries of the leg. So I want you to understand the PVD. The differences between PVD and PAD. PVD is that generic umbrella term. It can be many different types of circulatory diseases. PAD is one specific disease, artery disease, that falls under the PVD umbrella. and it only affects the arteries and primarily the ones of our legs. So examples, peripheral vascular disease, we can see peripheral artery disease. We can see Raynaud's disease, thrombosis, thrombosis, embolism. Men are typically more affected than women by peripheral arterial disease than women in the lower extremities. So we have a couple different complications that we can see as a result of peripheral artery disease, and you will see these in your patients that have had this for many years. So we can have something called critical limb ischemia. So this is when peripheral artery disease really worsens. You might see open sores or infections on the legs that don't resolve. Sometimes they become gangrenous, they're black, they are stinky. You can smell them when you walk in the room. You know that they have it. This will obviously threaten the viability of the limb, and ultimately these patients end up getting their limbs cut off. They have to amputate them. We can also have intermittent claudation. So this is an important slide. I want you guys to know this. So intermittent claudation is pain or cramping in your thigh, in your calf, or your butt during any kind of activity. The pain is not going to be there when you're resting, okay? It is relieved by rest. You guys need to know that. These extremities are going to be cold to touch. They're going to be cool. The patient might report that they have numbness. You're going to see lesions on the skin that are very slow to heal. These legs look terrible. You're going to see loss of hair in these limbs on certain parts of the legs. Their skin is going to appear red in the dependent position. It's going to return to normal when elevated. If patients that have intermittent claudation elevate their extremities and that blood flow or that skin does not appear to normal, that is an issue. You guys need to understand that you would want to contact the doctor. It should always return to normal when elevated. And then you should understand that you are going to have difficulty palpating their pulses. So you are probably going to need to do, you're going to want to go to that femoral artery, down to the popliteal, and for those lower pulses, the dorsipedalis and the posterior tibial, you are going to need to use a Doppler to locate them probably. And if you have to do that, if you're the first nurse to do that, please be a good nurse and mark with a pen where you find them at, because then the next nurse that comes by will love you forever, because then she doesn't have to spend an hour in the room trying to find where the pulse is, okay? So if we think a patient has peripheral arterial disease, we can do what's called an ankle brachial index. So this is this is a measurement to detect peripheral artery disease. It's a comparison of the systolic pressure in the brachial artery with the posterior tibial artery. And based upon the ABA number that they get, I put a little chart there, 0.9 to 1 would be normal, okay? 0.70 to 0.89 would be indicative of mild PAD. And then 0.40 to 0.69, moderate. Greater than, less than 0.4 would be severe disease. ABI is usually a very good indicator. It's 90%, 95% effective. All right, so how do we manage peripheral artery disease? So we want to encourage our patients to lose weight. If they are not obese, this will help. We want them to exercise daily. They should be exercising 3 to 5 times a week for 30 minutes a day. If they're smoking, they need to stop. We want to control their blood sugar. We're going to administer antihypertensives, lipid-lowering agents, antiplatelet agents, because we want to avoid them getting a blood clot, antithrombotics, and they might need percutaneous and revascularization procedures. It just depends on how severe it is. So things that we're going to want to educate the patient about. So we want them to participate in lifestyle changes. So we want them exercising 3 to 5 times a week, 30 minutes a day. We want them to have a good diet, lots of fruits, lots of veggies. a diet low in fats, moderate carbs, high in proteins, lean meats. We want to educate about their medications and adherence. So we want, if they're taking antihypertensives, we want them to take them every day. We want them to monitor their blood pressure at home because we want them to recognize if their blood pressure is too low. If we're giving lipid lowering agents, some of those are most effective at night. So we want to encourage them to take them at night because that's when our body makes cholesterol at night. So that the medicine works better when we take it at night. We're going to monitor labs for therapeutic levels. We're going to do skin assessments. I told you their skin is going to look terrible. So we're going to make sure we're taking care of those wounds, those open sores that are slow to heal. We're going to make sure we're doing wound changes. If we don't know what to put on them, we want to contact wound care center and have them come and take a look at the patient if your hospital has that. We're going to make sure we're doing daily skin care. So we want to wash and dry the feet very, very well. Any kind of moisture can breed bacteria. Bacteria can cause an open area. So wash and dry the feet very well. Apply moisturizer. Make sure we tell them at home that they should have supportive shoes. They need to have regular visits to the podiatrist for foot care. So they need to keep their toenails in check. They need to be taken care of, cut down, monitored for any kind of fungi infection. Remember, we said that some of these patients have numbness there, so they don't even feel that they have any kind of issues with their feet. So they could have open sores and not know it. So really take a look at their feet, make sure they don't have anything going on, encourage them to do that at home. Avoid applying high heat to the skin, especially those lower extremities, because it can cause more damage than good. And then we're going to want to make sure that we provide intermittent positioning of those lower extremities. So we want to get our patients to the side of the bed. We want their feet to dangle. This is an important slide. You guys need to know that. This is what a venous stasis ulcer looks like. Sometimes we develop these because of PAD. This is actually a mild one. Sometimes they are big and red and they have slough on them. They're yellow and they stink. They really, all these wounds on the legs really, really smell. But that is a good picture of a person of what their legs would look like that has peripheral artery disease. So now we have Raynaud's disease. So Raynaud's disease, these are brief spasms of the arteries and arterioles in the fingers. It can happen in your toes, it can happen in your nose, in your ears, and in your chin. And what it does is it causes temporary ischemia to the tissues. So you can see in this picture here how white the ends of these fingertips are. This can go on for, it can happen periodically through the day, once or twice. It can go on and off multiple times through the day. When this happens, it could happen for 10 minutes. It could happen for an hour. It just depends on the severity. Every person's different. It is very, very common in young women. The vessels dilate very wide to compensate for the restriction. So then you get these patchy areas of necrosis that accompany these prolonged periods of ischemia. They say that they last approximately 15 minutes in the clinical setting. You always have differences in that. I've seen them last a lot longer. I've seen them last less than 15 minutes, but I guess an approximate number would be 15. So you're going to see these are especially common after exposure to the cold. So, during the winter months, there's going to be more predominant. The hands are going to be cold. They're going to be blanched, but they're also going to be moist. They're going to have perspiration. Patients may report numbness and tingling. They may have difficulty with fine motor movement. They may appear that they're awkward and they're fumbling because they have that numbness. They don't have that great feeling in the ends of their fingers. And of course, if it's happening in their toes, then it might appear that they're stumbling a little bit when they're walking. After that initial pallor, the hands, especially the fingers, will become very cyanotic, and then they also become painful. So patients will report that they have pain. And then the hallmark signs of this disease are that ischemia, pain, and those paresthesias, which are numbness and tingling. So how are we going to medically manage these patients? Well, we're going to avoid factors that precipitate attacks. So in the winter months, we want to educate them to bundle up, make sure you wear gloves, especially when you're out in the cold. If you smoke, you want to stop because we all know that smoking causes vasoconstriction. It'll make the disease worse. And then we can treat with medications that will allow for vasodilation. So we're going to use those peripheral vasodilators. If it's so severe that they need surgical management, we can do a sympathectomy. So this is where they actually go in and cut the peripheral sympathetic nerves. And then sometimes if the disease progresses, those they can develop gangrenous areas because you're not getting enough blood flow to the area. And then those turn black and they smell really terrible. And then you have to get them amputated. So nursing management, you can warm the hands in warm water, warm blankets. You can provide imagery. So they have something called the McIntyre maneuver, which is a swinging motion of your hands back and forth, which is going to help distribute the blood to the distal areas of your fingers. We want to encourage these patients to wear wool socks and mittens. Wool is very, very warm, so it'll protect your hands and your feet. We also want to tell them to avoid over-the-counter decongestants, different cold remedies, and drugs for symptomatic relief of hay fever, because these all cause vasoconstriction. So it'll make it worse. And then again, just educating those patients about wearing gloves. Wearing gloves during household chores, gardening, washing dishes, because remember, they could get an injury. They might have numbness and tingling. They might not feel it. So education, education, education. Varicose veins. So what happens with varicose veins is that the valves in our veins become incompetent. Blood will accumulate rather than be propelled to the heart. That congestion of blood stretches our veins over time. They lose their elasticity. They cannot recoil again, and they remain chronically distended. So what causes varicose veins? Well, prolonged standing will compromise our venous return. So who do you think is at a high risk of developing varicose veins?
Nurses.
Yes, nurses. We're on our feet all the time, 12 to 14 hours a day. If we're overweight, obese, it's going to put a lot of pressure on our veins, pressure on the blood vessels from an enlarging fetus. So we see these in our pregnant mamas. Liver or abdominal tumors can also cause it. So what are our assessment findings? Patients are going to say that their legs feel heavy, they're tired, particularly after prolonged standing. Activity or elevation of the legs is going to help relieve that discomfort. It's not going to make it worse. Our leg veins are going to look distended or tortuous, and then they can be seen under the skin when you see them. They can be dark blue. They can be a very dark purple. Some of them even look black. They can be very, very puffy. They kind of look snake-like. They can be really long. Some of them are short. They're elevated off the skin. They all kind of look a little different in different people. So how do we diagnose varicose veins? We're going to do something called a Brody-Trendelenburg test. This is where the client lays flat. They elevate the affected leg to empty the blood from all the veins. They apply a tourniquet to the upper thigh, and the client is asked to stand. If the blood then flows from the upper part of the leg into the superficial veins, when the tourniquet is released, the valves of the superficial veins are considered incompetent. That's not something that we do. They go off the floor to have that procedure done. They can also have an ultrasound or what's called a venography. So what kind of medical management? We can encourage them to exercise, walking and swimming. We want them to lose weight if obesity is causing the problem. If it's nurses or someone that's on their feet all day, wear those elastic support stockings. So I don't know if you work in the medical field right now, but I always, if I don't wear, sometimes if I'm running late in the morning, I don't want to have to fight to put those stockings on, because it can take you a minute to get them on because they're really tight. And if I don't wear them, I notice by the time I get home, sometimes my ankles are swollen and my legs just hurt. If I wear my stockings, they're never swollen. They might itch a little from having the stockings on, but I never get that leg pain. So they're really, really helpful. So make sure you're wearing your TEDs, and then avoid prolonged periods of sitting or standing. We can do surgical management, so we can do something called a vein ligation. This is where the veins that are affected are actually tied off. They cut them above and below the areas of the incompetent valves. Then they can do something called vein stripping. This is where the ligated veins are severed and they actually remove them. So for nurses, we are going to want to make sure that we assess the skin. We're going to be looking for those areas. We're going to check the circulation distal to those problem areas. We're going to check for peripheral edema, any swelling. We're going to assess the client's level of discomfort. Do they have any pain? Do their legs feel heavy, numbness, tingling? We want to see their ability to do active and isometric leg exercises. So PT is probably going to come, or OT is going to come work with them and determine that. Ambulation post-surgery. So as soon as they have surgery, even patients that have hip replacements, we get them up within an hour or two of having surgery. Knee replacements, up the same day. We want them to get up, even if it's just to the chair. We want to put anti-embolism stockings on our patients, make sure they have those SEDs, and then just some educational points. We want to educate our patients to avoid sitting with our knees crossed, because that can cause these varicose veins. Avoid standing for long, prolonged periods, and then avoid wearing elastic girdles and tight belts. I don't know anybody that wears girdles nowadays, but I guess some people do if it's in our book. So this is just a great picture of those veins, how they look. You can see in this first picture here, this right leg, how distended those veins are. These littler veins here, they're not as bad yet. They're just minor ones. He's got some over here too. But you can see in this second picture, this left foot, how snake-like they are and how predominant they are. It's going to vary by each person depending on, their different circumstances. So next, we're going to talk about aneurysms. So aneurysms are stretching and bulging of an arterial wall. These can happen in the aortic arch. It can happen in the thoracic and the abdominal areas. Those are the most common. What causes an aneurysm? It can be arterial sclerosis. It could be chronic hypertension, so hypertension that is uncontrolled, any kind of trauma to these areas, or it can even just be a congenital weakness. It affects the elasticity of what's called the tunica media, which is the middle layer of that artery wall. It causes part of the vessel to bulge. Once formed, many aneurysms lay down layers of clots, blocking the vessel until blood flow completely stops. Most aneurysms will continue to enlarge until they rupture. Rupture obviously is going to cause the loss of large amounts of blood that's going to lead to shock or death. So I've seen it multiple times in our patients. They have what's called a triple A. So that's what you'll hear in the healthcare setting. It's an abdominal aortic aneurysm. And they measure them, they identify them. Usually they look at them by size. If they're up to a certain millimeter, they don't do anything to them. Once they reach a certain size, then they go in and they try to surgically take care of them, because you don't want them to rupture, because if they do, your patients will bleed out extremely quickly. Sometimes with these patients, you will see, it's actually in this next part under assessment findings. So they usually go asymptomatic. The patients don't have any signs or symptoms until the patient starts to have a massive hemorrhage. They can be painful. They can cause discomfort in some patients. Symptoms are going to be really just related to the pressure that growing aneurysm has on the nearby structures. And then most patients that have this are hypertensive. And sometimes you can see a pulsating mass. You can see it, or you can feel it around the belly button, or just left of the midline over the abdomen. And you can actually see it pulsating. And sometimes if you put your hands there, you can feel it pulsating. So how would we diagnose one? Well, we can do an ultrasound. That is the gold standard. That is the most common way that we diagnose a aneurysm, is to do an ultrasound. And then we can do an arteriography, which identifies the size and location of the aneurysm. So medical management, well, we know if it is caused by uncontrolled hypertension, then we are going to want to make sure that we control the hypertension. So we're going to administer hypertensive drugs to keep the blood pressure in that normal range. Sometimes they need surgical intervention. They need to do a bypass or a replacement graft where they cut off an area there and they reconnect it to another area. So nursing management, what are we going to do? We want to keep the client as stress-free as possible, and we want to keep their activity to a minimum because we want to help control that blood pressure. Blood pressure is crucial, especially in those triple A's. So if you see a patient that has a history of that, you should automatically make that correlation that I need to control this patient's blood pressure. You want to tell the patient not to strain during bowel movements. So you want to ask, when was your last bowel movements? Was it normal? Did you have any problem going? If they have any problems, you want to make sure they have a stool softener. You want to teach them that when they're coughing and they're holding their breath while changing positions, they don't want to strain. Want to monitor their vital signs, make sure their blood pressure, their heart rate is good, monitor their I's and O's, monitor their level of consciousness. If they're having a bleed and they're having that huge loss of blood, we're going to see it in their vital signs and their level of consciousness. And then we want to really know what their characteristics of their pain are. Do they feel something pulsating? When do they have the pain? Does anything make it better? And then we're going to do that skin assessment. We're going to look for the color and the temperature. Is it cool? Is it warm? Is it blue? Is it pink? Really want to be descriptive. All right, so let's test your knowledge. Which instructions should a nurse provide a client with a history of rheumatic fever before the client has any dental work? Do we want them to take steroids, take an aspirin before they go, take prophylactic antibiotics, or to avoid any kind of activity? I'm going to call on somebody because although I love to hear from you, Sung, you're the only person that's answering, and I know you probably already know the answer. Sarah, what do we want to do?
C.
C, very good. We know that any patient that has that endocarditis or that rheumatic fever, they're always going to have to take lifelong prophylactic antibiotics before dental work and having any kind of procedure. Good job. All right, next question. Which nursing intervention would reduce cardiac workload in a client with myocarditis? Maintain the client on bed rest, administer a prescribed antipyretic, lower the client's head, or eliminate all phone calls and visitors. How about Ariel? Ariel, are you there?
Yes, I'm here. I'm rereading it again.
Okay.
It's in the client on bed rest, administer the client's head. I would say A.
Yes, very good. So we talked through a lot of these, that with a lot of these heart issues, the myocarditis, the endocarditis, the pericarditis, we want these patients to be on bed rest. We want to make sure that we're minimizing their activity so that they can save their energy. Very good. All right, let's see our next question. All right, the nurse is documenting assessment findings as a client is being admitted to a medical unit. Which of the following conditions present with a diagnosis of infectious carditis is correct to be documented as petechiae? So we want to know, what is petechiae? Is it purplish, painful nodules? B, black longitudinal lines in the nails? C, white areas in the retina surrounded by areas of hemorrhage? Or D, reddish hemorrhage spots on the skin? How about Marzina? What is petechiae? And it's okay if you don't guess right. We're all here to learn.
I'm thinking, thank you.
That's okay.
Petechia. I think I need a help.
You want to phone a friend? Let's
Yes.
phone a friend.
D.
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 Yes.
D.
The answer is D. So petechiae.
Okay.
D. Yep. Reddish hemorrhagic spots that we see on the skin. They can be anywhere: hands, arms, legs, abdomen. Very good. So the answer was D. All right. A nurse working at a pediatric clinic is teaching a group of parents. A parent asks the nurse if it is okay to let a young child recover from a sore throat naturally rather than bringing the child to the clinic for diagnosis and treatment. What is the nurse's best response? A, it may be streptococcal sore throat. Rheumatic heart disease can be prevented with early treatment. B, it's fine to let the child recover naturally. It will save you time and money. C, it's not a good idea to give antibiotics for every sore throat that your child has because of the overuse of antibiotics. Or D, healthcare providers tend to overtreat children with antibiotics so the children recovers quickly. Let's see, how about Tia? Tia, you want to try and answer this question? Tia's missing. All right, Angie, do you want to try and answer the question?
Yes, it's A.
Yes, very good. We know that if a child or a patient has strep throat and we don't take care of it and manage it with antibiotics, left untreated, it will turn into rheumatic disease. All right, Ralph Wilson, a 52-year-old client in the hospital unit where you practice, is a client, sorry, in the hospital unit where you practice nursing. He is being treated for myocarditis. Which of the following nursing interventions should you perform to reduce cardiac workload in a client with myocarditis? Maintain the client on bed rest, administer a prescribed antipyretic, elevate his bed, or eliminate phone calls to visitors.
Didn't we just do this one?
Is this the same one we did?
Yes.
Yeah, this is the same one.
Not the same one. It's just a different scenario. But I want you guys to understand the importance of this. So this is why I'm saying it again. So the answer is A. We want to make sure that these clients stay on bed rest. So you are going to see a question similar to these two. Okay. So I want you to understand the importance. All right, in which type of cardiomyopathy does the heart muscle actually increase in size and mass weight, especially along the septum? A, hypertrophic, B, dilated, C, restrictive, or D, arrhythmogenic right ventricular? Let's see. Tia. There she is. You were missing. A, very good, hypertrophic. All right, very good, guys. That is everything for your first lecture